many of you may not be acquainted with this kind of topics, but this is a very upcoming topic of public health of today's world. Okay. So please write your names in the forms which we are providing. There are very attractive prizes which have to be won after the workshop, depending on the activities, and also some very interesting gifts. So I request you to stay till the end because only then we shall actually know what this session is about, and try to participate as much as possible because your participation is the thing that will make this workshop a grand success. I am now handing over to Shamma Yasmin, who is the hall coordinator for this hall.
And if you attend the entire workshop, we have the reading material for you on a pen drive, very interesting reading material. We also have some wonderful prizes to be won and some activities that we have through the day. So I request all of you to stay on. Let's quickly finish registration so that we can get on to the technical sessions. We'll run you through today's sessions, and after that we have a very interesting debate. Okay, and I'll just announce the topic for the debate. Everything we talk to you is going to be related to the theme for the debate, and I really encourage all of you to come forward and take part because there are some very interesting prizes. The theme for the debate is doctors are most strategically situated to address violence in women's lives. Okay, so that's the theme. Did all of you receive invitations for the session? Yes? Yes and no, both. Doctors are most strategically situated to address violence in women's lives. You will have sufficient time. We give you 25 minutes to prepare. You can probably get into little teams and then prepare, and then we'll have the debate. That's towards the end of the day. So just while you're all signing up and settling down, we'll just take a few minutes and prepare to start. As many people would like to speak should come up and speak education and what the problem is. I'd just like to begin by stating that for many, many years, in fact centuries now, women's status has been exclusively associated with maternity and reproduction. And this is in spite of the fact that women really have no control over their bodies or the reproductive process itself. And women's health issues are either not fully addressed or not addressed at all from a perspective that would empower them to have fewer children also. I mean, if it's associated with reproduction. So this is also a missing link entirely. If this is the situation, we do not acknowledge women's existence beyond their reproductive functions. Because of this perception, health programs in general and medical education in particular, we feel really lacks. Trained in bioethics at a fellowship program at the Harvard School for Public Health and is currently the member secretary of the Institute of Ethics Committee. And she...
Very good morning to all of you. Before we start, can we have at least a brief introduction where you come from? All of you are from the medical college? Any person from other than that? Okay. All of you are in which phase or year? I would like to briefly, someone was telling they are graduating into the third year. Okay. Some are from All India Institute, okay, attached to the health itself. Yeah.
Dr. Jagdish, can you introduce themselves very quickly, just their name and which college, which year? It will take 5 minutes.
So how many of you are from the second year? A few also. So my discussion would be on why gender matters in medical education. Is this a difficult question? Can you easily identify the sex of a person? What's the sex of a person? What do you understand by sex of a person? Sex of a person where we try to classify them as male or female. How you do that? So that is based on the biological differences, chromosomes, hormones, internal, external sex organs. So that's what you learn in your anatomy, or that's what you learn in your biology much before you enter the medical college or the health institutes. So that's something which you all got it at an younger age in differentiating these human beings into male and female. Can you attribute any things for them based on the sex of a person? Do you agree? Do you agree? So these are something which come out from our biological differences. Now what is this then? If that was sex of a person, then what is this? Many a time in our own medical books, these two are used as synonyms. Are they synonyms? Definitely not, because we are conducting a workshop over here. Definitely it would not be. So they are not synonyms. So that means it's something different. Okay, without wasting time, I try to introduce you this term of gender. So gender is the social construct of a person, or how the society looks at a human being. Is it different from you being called a male and a female? Is it different? Are you socially looked in a different lens? So gender describes the characteristics that the society or culture delineates you as masculine or feminine. So that means a male can also exhibit certain feminine qualities. Many a time it's a common thing if a boy, a little boy is crying, the elders in the house would be saying, why are you crying like a girl? Is it something the society is attributing? Is it something? And the girl is trying to wear pants and get out of the house in the night. Why are you not a boy? Is it something the society pushing on us? So that's what we are looking at, refers to women's and men's roles and responsibilities that the society determines. Does it affect medical education? Does it affect health of a person? This social construct of a person into a masculine quality or a feminine quality, does it affect health of this society? So look at this example. So this again from Vietnam, where the number of men smoking is more. That is because the female smoking is not traditionally considered properly. This again is an example of the social construct. There were offshoots of that. Recently that lady was also arrested and punished in Saudi Arabia. So that means it's not limited to India. This is globally present. So this is about the facts on women's health by the WHO. So now we try to look it with the interface of health. Look at these examples. Tobacco use among younger women in developing countries is rising rapidly. Do you agree? Do you agree? India also, that's how we have got ban on several of those. The HIV epidemic in sub-Saharan Africa is increasingly female. This is again based on the research studies which have come out. So what was considered something on the male is now on the other side of the spectrum. Violence, intimate partner violence has serious health consequences for women. So we have a topic later in the day. This is widespread throughout the world. Though early marriage is on the decline, but young married girls often lack knowledge about sex and the risks of sexually transmitted infections. Do you agree? Most adolescent mothers are living in developing countries. Does it have impact on the health? Essentially, all maternal deaths occur in the developing countries. Almost 99% comes from the developing countries. Is it a matter of concern? When women earn an income, they are more likely than men to buy mosquito nets for their households. This is how in the control on malaria they have brought out this research evidence. When the male also earns, that is not translated into the prevention, but when the female is earning, that is translating into the prevention. The burden of COPD is 50% higher among women. Do you agree? Or you want to think over? You want to think over? Women have a higher risk of becoming visually impaired than men. Do you agree? Or to think over? Earlier statements you agreed. Now these are the newer evidences which are coming out. There are diseases which are affecting men and women, but women are not seeking that health care when it is required. When it is required. Even if they seek that health care, it is not complete. So that is affecting them and making them blind. Likewise, the burden of COPD is also what was considered as a male disease is now looking out with the research evidence. We are looking at the women also. So thus how we approach in the medical education to this disease or in trying to curb or curtail or treat this disease, so should it alter? So why gender matches in medical education? Because men and women differ in relation to the physical spaces they occupy. Do you agree? The tasks and activities they perform, the people they interact with. The gender-based differences, now we come back to the issue. In roles and responsibilities, access to and control over the resources. Is it same? Men and women have the same resources? And power in decision making. Do they enjoy the same decision making power in the family, in the community, in the society? So that affects the women and men's health. It is not only affecting the woman's health, it is also going to affect the family's health. So that is going to be a burden on the society. So unless until we address this, this is also a social determinant of health. So we have to address this, and that's the concern. So I try to give you some examples. So gender-based difference may result in differential risks and vulnerabilities to infection and health conditions. I think sexual violence is on the rise, and you all agree to it. And how the society looks at it? How does the society look at it? Does the medical community differ in any way from how the society looks at it? Is the medical community sensitive enough in looking into it? So in the later part of the discussion we are going to address that also. So that means the vulnerabilities. Even the medical community where we are, so we are also perpetuating the same biases of the society, whether consciously or not knowingly, and that is affecting. Today, a sexual violence violated woman or a child, they should find the hospital as a safe place. Are we a safe place? Have we developed our infrastructure or resources in such a way that we are receptive to them? Or are there barriers in approaching of these people into us? Different perceptions of health needs. Many a time people don't come. If the male member has a backache, next moment he is in the casualty. If the woman member is having the same problem, is it the same concern? Is it the same concern? Last week there was even a report on cancer or malignancy. There are more number of females who are detected with cancer. Though the deaths are with the male more, but more number of women are being diagnosed with cancer. Why? Because they neglected. Early detection is not occurring over there. So they are not seeking your health care immediately. So that's again, is there something to do with the social aspect? Is there something to blame with the society? When both are equal, when we are fighting Article 14, right to equality, are we not giving that? Different access to health services. We all boast of our DOTS program. DOTS program is for your tuberculosis, where you directly observe and give your drugs. So this is a modified program so that the drugs reach the person and you are able to curtail that. When you start your OPD, morning 9 o'clock or 8 o'clock when your OPD starts, all the male members are making a line. And when you are closing your OPD, you find some female coming. As a healthcare provider, what is your response? You say, why you are coming now? I am closing. Why can't you come in the morning? Did we ever bother what prevented that woman in coming at 9 o'clock? That woman had to finish her routine household works, which the society has put on her, take care of the kids, and then find an opportunity to reach your hospital. You opened your DOTS program thinking that you are going to stop TB. But you never bothered in looking at whether this social construction of a person is affecting in receiving those services. Different consequences and outcomes. We all are students of science. We all know that to have a girl child you need 2 X chromosomes. And the woman can always contribute only X chromosome. Who is the other contributor? So who is the deciding factor for the birth of a girl child? It's the male partner. But how does the society look? The society looks that she is the one. Different social consequences as a result of ill health. We all know HIV infection is due to various means. Needle stick injury, blood transfusion, and sexual transmission. When a male gets, you look into all those. But the society, the moment there is a HIV infection being diagnosed in a female, first to die, first to blame is promiscuous. First to blame. And this is taken even by the medical sector. You also look into the same angle. Is it always the same? By your comment on that, is it going to affect her care? Is she going to come back to you? Is there any problems in approaching the health sector? Should we try to modify our approach? So does sex and gender influence health and well-being right throughout the life of the individual? It's not at any particular lifespan. It's the entire, right from womb to tomb, this is there. And understanding the implications of sex and gender difference in patients is a vital, a good clinical practice. We may argue this, we were not talking, our books were also not speaking on this. All these centuries we learned medicine. Why now? Now we have got evidence. So it's time to change. And if that is a good clinical practice, so if it is not occurring everywhere, at least let us start from here. Let us start from ourselves. So we should be the change agents. Coming back to a different level in looking at this, can you answer this? What are the major symptoms experienced by patients suffering from acute myocardial infarct? Yeah? Pardon? Sweating, chest pain. How do you qualify chest pain? Left, radiating. Yeah? So crushing chest pain, radiating to left. arms. Do you all agree? Do you all agree? So that means all patients of MI will have this. All patients of MI will have this. That's what you learned from your medicine books. Yeah? Or is it limited to only male patients? Did you ever look into it? Am I challenging the medical authorities? The so-called textbooks which you all accepted as Bibles, Qurans, and Bhagavad Gitas, and whatever is written on that is gospel truth. Is it so? The research evidence puts out they all are from the male patients. Then what are the symptoms of the female patient? Did you ever bother? This is a survey which has come out and published, not from here, America itself, 2004 itself. Anybody interested can go more deep into it. And these are the things. Anywhere of the previous slide is mentioning there. So that means if these people come to you, you are not going to make a diagnosis of acute MI. And if you are not going to make an acute MI diagnosis, you are not going to care for them. Is there something to affect how you are being taught? Is it something to do with what is the research available and we are blind? So this is what is known as gender blindness. So that means you have never bothered to look into what is the sex disaggregated data. Are features different in different sexes? Then you are blindly following what is there. Because our book speaks. Book is written by whom? One more doctor like ours. It might have been apt and correct for that time when the research evidence was not there. But when the research evidence is available, then today you have to modify it. So that's the golden principle. Medicine or medical education should always be learned from recent. Though you have West Bengal University of Health Sciences, I'm sure your book, your university also does not say this is the only book you have to read. Do they say so? And even if they are giving the curriculum, that is not going to end. If something new research comes today, you can't say my book does not speak of that, so I am not going to treat you with that. If something new comes, you have to update. Likewise, if something new research evidence comes, it is high time we update. So I gave you one example of acute MI. Did you ever bother to look into any other diseases or old diseases like this? Are there any factors which are going to affect? Unless you see into it, it is not going to be known at all. So thus, from the patient's perspective, acknowledging the differential roles, that is with either the masculinity or femininity which puts out, so that is their concern. Are there any concerns in that way also? Are the patients also different in approaching the healthcare? Look at this example. So this is again a study which is published from 2000 in JAMA, that's American Medical Association. So in the emergency room treatment for unstable angina, men have a greater rate of procedures than women. Suddenly I have a chest pain, I have rushed to the nearby hospital and I am investigated. Same thing if it is on a female, the number of studies done in men is more than on the woman. There is nothing different in India also. India the numbers could be still worse. But men still suffer from worse outcomes. That's a different thing. That's based on the severity and the other factors. But the number of procedures which are, why it should be different? When your Article 14 says both are equal and both are belonging to you, is there anything to do with us as the healthcare provider? Or is there anything to do with this society that, okay, male you have to treat, female she could afford. Is there anything? Coming back to our own things, I'm sure all of you have finished your anatomy, irrespective of whichever stream you come from. Is there anything, a bias on this in our book? Most of the medical texts contain diagrams that show the human abdomen with a testicular artery, if not male genitalia. If you get back into your own anatomy books, whichever book, which is a popular book here, Chaurasia? No? Chaurasia, which is from West Bengal. So, to go back, I'm not joking, go back, check yourself. It's the same thing in your book. Human abdomen, testicular artery, if not, again in certain places, male genitalia. That is put titled as human abdomen. Is there any problem with this? So that means whether we are a male or a female student, we are also trying to internalize the same thing. If you look into the injuries also, it is the same. Male model is put. So what we learn, whether we are a male or a female student, we learn injuries are only on males. Injuries are not there on the female. In reality, so that means what you don't register here, your eyes is not going to see. Your eyes are not going to see. So what should have been the correct title here? The correct title should have been, this is a picture of a male abdomen. Does it make any difference? Does it make difference? Or is there any problem in identifying this? Today we are talking on evidence based. What it is? It's a male abdomen. Why you want to title it as a human abdomen? Why you want to put it as a neutral term there when it is not signifying that? So thus, gender perspective, the medical evidence acknowledges the clinical consequences of a gender-blind medical research and the resulting medical evidence. For the patient, it acknowledges the different roles the masculinity and femininity plays. For the medical education, we identify the gendered nature of our text, teaching styles and environment. For the clinical practice, it acknowledges the way in which the sex or gender of the patient impacts on clinical testing, diagnostics, treatment and outcomes. We are more concerned with this. So try to look out, is it something unique to India or something occurring globally? So looking at the international experiences, they have already done a lot of things of integration into the various courses. The curriculum, the policy changes, all have occurred. I'll quickly run through those examples so that you would also look at why in India the MCI or the West Bengal Medical University should not do. I'm very happy. Maharashtra they have done. Maharashtra University of Health Sciences is the similar counterpart of your West Bengal Health University. They have already started the program and they are trying to integrate it. So let us look into what is the international experience and then come back. So this is from Monash University of Australia. Anybody interested can get into the website. So you could Google it also, you could find that. What they have done, so Joe Weiner is one of the gender activists over there. So there was one shortage of the rural doctors. The government shortlisted her to do a study. And she expanded that. And at that time there was a curriculum change in the Australian universities also. She tried to integrate gender into the problem-based learning of the curriculum which was initiated. So they tried to introduce all that what we taught for the last 20 minutes. So I just gave a bird's eye view. So they tried to look into it in more details in everyday seminar, tutorials, try to look the case studies and also introduced into the assessments. And thus, they also did not stop at that level. So in Monash University, they are trying to look out why women are, or how women are trying to get into the medical education. Is there a problem in women having medical education? In one of the medical university, we had a rule saying that you can have maximum 3 attempts or 5 years in your course. If you fail in that, you discontinue the course. there any problem? There were a few postgraduates also here. If your university says that if any student does not complete the course in 5 years or in 3 attempts, so you will discontinue the course. Is there any problem? Is it going to affect a male student and a female student differently? No? No? Even the place where I come from, the Karnataka, we also have a health university. We also had the same rule, which was challenged in the High Court, and it was quashed. It was again brought out by the female medical students, saying that there are certain roles for them. Suppose she marries, she opts for pregnancy, and these roles she loses that 5 years over there. In your collective thing, that 5 years will cross. 3 attempts also are lost. So when you are planning something, you have to look into it. So this Monash University looked at women could have an interrupted teaching. So that means, unfortunately, in India, our MCA also has to look into it. So we say that no, 4.5 years you have to complete and 1 year internship. If you interrupt, there are problems. So there they have allowed interrupted and part-time training for the women. They are also allowed to contest the knowledge that excludes women's perspectives. So they are challenging the existing medical literature and looking into the newer way, and that's how they are looking in Monash University. In Thailand, so there also they started with an organized way of a core group going into, they came to India and learned about gender. Then they tried to do an analysis at their own level. They integrated their curriculum already for near a decade now. In their UG curriculum, they already, for the last 10 years it is there. They have integrated in both in the pre-clinical subjects and in the clinical subjects on these areas into the existing subjects. So that means the same diseases, same conditions, what you are looking from the gender angle. It's not something new. You are trying to look into every aspect of what is your medical education, are there any gender issues? And trying to look that. So they also have picked up problem-based learning, case discussion, and they have also included in assessment. The outcome is positive, not only in the medical world, even in their personal life. Even in the personal life, they have modified their things. So are you different in your personal life and in your medical life? So that's the debating issue in the afternoon. So in Turkey, so there also they brought out sexual and reproductive health. So that was one of the offshoot of the reproductive health program. So they tried to integrate gender there. So they tried to introduce in medical nursing curriculum also. And they initially did a needs assessment where they stand, what is the understanding of gender. They developed a curriculum which is needs based into both medical and nursing, and they tried to do the training of all the medical faculty of that medical school which was introduced, and then they evaluated. Immediately there was a positive response in nursing. In the medical education, there were certain obstacles. Why? Your faculty also has to be trained. Your faculty also has to be trained. The books, the evidence what you read should also be available. That is lacking. Overnight somebody will put a magic wand. Will somebody put a magic wand and you get it? So that means you have to open your eyes. You have to initiate. So I am very happy that the World Congress on Public Health thought this as an issue and to introduce into the young minds of at least of this part of the medical students over here, so that this is a challenge. And now we have to initiate and find out evidence on this. Philippines, so they found out their doctors were not able to handle family violence beyond injuries. If somebody comes out, there is a family violence, domestic violence at the household, that person comes to you, what's your response? If they have injuries, you paint your tincture iodine here and there, maximum you give a TT and send them back. Does your job end? Does your job end? Then what should you do? You can't go into their household and stop that violence. But can you initiate certain steps to stop that? So that's what you are going to learn in the later sessions. So this was a pilot project in that medical college. So they tried to pick up culture sensitive, gender sensitive and compassionate physicians with effective communication and counseling skills. So that was the objective with which that project started, and they tried to look for integration in their undergraduate curriculum, and the outcome is a positive thing. Likewise, in Uganda also there is a entire Makerere University. They thought that we should gender sensitize. So look at the years. We are talking in 2015 now. All these small countries have already started when? 13 years back. So they are already identified they should have a gender friendly environment. This is the, how is it here? How many medical female students are in your classes? Male students? Is it 50-50? Different? Why? Okay. Now the females are outnumbered. Did you ever think just 20 to 25 years back the number of female students who are in counting fingers? Not only in India, even in Canada, USA also. And even if those were there, the people selected subjects were family medicine, obstetrics. Today we have women in every walk. So gender is not an issue only in medical education. Gender is not only an issue of the WHO. Gender is an issue of the United Nations itself. United Nations is trying to address gender concerns across all its subsidiary organizations. So that is how it is going on. The whole globe is looking at how to gender mainstream. And if we don't, we fall back. So they introduced COPES or community-based education and service. So they tried to look at in the community. So they thought in the community medicine how we could look at these issues, the impact of gender power relations, division of labor, access to health resources. They tried to look at even gender in the community research. So you have given all community postings, so they tried to look into that and see what is the gender concerns even in the community. So that's a different example. So this side, I want all of you to look into it. This is from Canada. So Ontario Gender and Health Collaborative Curriculum. So it's a web-based, so that means everybody can access that. 2006 they brought out 16 modules. They have looked into almost all. Are there any problems with this? We already looked at acute MI. Are there problems with lung cancer? We already looked in COPD and other. Poverty, is it a concern? Sex and sexuality, are there concerns? So they try to look into even advocacy, professionalism, ethics and likewise. So this is manned completely by the medical students. The program is run by medical students. And there are project leaders and other faculty who are supporting it, but it entirely runs on the students. They have all these interactive and self-learning exercise because it's a web-based model. And it is easy to use, flexible, and there is no competition for teaching time. Suddenly if I introduce, say that, okay, I initiate your teachers who are here to say that now from tomorrow you have to teach gender. You already have a structured program, so where to fit in. So that is one of the reasons in the other examples also, unless until it is a policy decision from the higher level, it was difficult to integrate immediately. So that's not a concern here because it's a web-based. So people at their ease, at their time, at their convenience, they can also pick up that. So that is there. In USA, so they started, this is an association of professors of gynecology and obstetrics. So they thought that how to address that into the women's health. So what they built out is a web-based curriculum builder. So there they brought out evaluation tools and how the linkages into the residency program. Several universities in USA are looking. If you are planning to go abroad and look into it, these are what you are going to look there. Why it cannot occur in India? So they are trying to look. These are certain concerns which they are looking. Explain sex and gender differences in normal development and pathophysiology. Effectively communicate awareness on gender and cultural differences. Perform sex and gender in age appropriate physical examination. In the due course of the day, you will learn how all we are violating, even your normal medical examination, how you are violating the gender concerns. Discuss the impact of gender-based and societal cultural roles on healthcare. I think I brought out several examples of it affects. Identify and assist victims of physical, emotional, sexual violence. We are not only restricted to sexual violence, there are other sorts of violence also. How to address that? There is an entire session. Assist and counsel. Are we counselors? Do we have those abilities to do that? If we are not able to do it, what prevents us from learning it? Assess and critically evaluate new information and adopt best practices. So that's what we have to open our eyes and look into the new research evidence, what is coming out. Rather than picking up my dad's book or mother's book, so I read that. If your dad or mother happens to be a doctor. Is it appropriate? Can you read that book? So likewise, there is one more example from the United States. They have got residency programs over there. There are 7 residency programs where they are integrated. So these are one, adolescent medicine, emergency medicine, family medicine, internal medicine, OBG, pediatrics, psychiatry. In all these, they have integrated gender concerns. So that means in all these areas there are gender concerns. We did not look at it. Already, the other countries, they have already gone much ahead of us. They have integrated into all levels. And they are looking at newer, innovative ways of projects and trying to motivate people. So all these are available on the net also. There is one more example from the Medical Women's International Association. So they have picked up in 12 countries such workshops. But India does not figure there. So they are trying to look out the gender issues, and one the latest thing what they have put out in their website is the information package which they have addressed to the deans of the Australian medical schools. So specifically looking into one country and trying to address that in that context. So what I want is from all these examples we have to pick up and see how best we start in India also. We already have an example from Maharashtra which my next speaker is going to speak on that. So it's high time, it's not only limiting to Maharashtra, it should be there across India. So Indian doctors should not be somebody who is gender blind. Indian doctors should not be looked down, you are insensitive. Indian doctors should not be looked down that you are incompetent. So the WHO also has brought out a curriculum. So that's also available on their website. So this they have already integrated with the 3 partners, Harvard Public Health and from South Africa. 6 modules, 3 foundation and 3 application modules. So they have picked up all these concepts over there, and it's already implemented in 10 countries, and the beauty of it is already it is available in 5 different languages also. Even the Arabic language they are already put up. So that means it's more touchy if you are learning it in your own comfortable language. So what are the lessons learned globally now? Policy directives. We already understood there were certain concerns in certain places when it was immediately introduced into the existing curriculum. So there should be a policy direction from the higher up. So the MCI should immediately recognize. So there is an ongoing exercise right from, I remember Achyutam and Central in 2003 itself we wrote to MCI. At 2002 only they were on board, they were brought on, but you all know what are the problems in our own the regulatory body. So still we have not brought it into the integrated curriculum. Now we have a good opportunity because we had Vision 2015, okay, for some issues it was scrapped. Now we have Graduate Medical Education 2012, which is the medical education curriculum which you are reading. Are you aware? Are you aware? Go back to your library and check which is the curriculum. You are all reading 1999 The world is in 2015, but unfortunately in India we are looking at 1997. In this last 18 years, nothing has changed. Has it changed or not? So today is user-friendly thing. So it should be a demand this side also. So we are fighting with the MCI and the central government for last several years. Why are you not implementing the new gender graduate medical education of 2012? 2012, we are in 2015, still it's not released. The latest RTI application which we filed last week says that still it is under the process of consultation. So that's where we stand. And that doesn't mean I close my eyes and drink milk. The others have already gone. So we have to now look, this is a need-based program. We have to update ourselves. So we need motivated educators. Good, agreed, web-based program, but at least there should be a role model to inspire you. There should be a trigger person in the faculty. If I have to get into your own medical college, there should be somebody, your policy person in your college whom we should approach. Through that it should get into your college. Availability of learning materials, support for developing materials, we are all looking at a knowledge center. So already such a web-based program, Padma is going to talk on a little later. We have a website wherein all the pooled data is available, even in India, which is appropriate to this. So why can't we share that? It's open to everybody. Why can't we share that and see that ourselves we update? There are resistances. So unless when we started with the debate or a topic for the debate, you are also not convinced. At least I feel, okay, we have with this 1 hour of session or 45 minutes of session, we have at least brought in some inputs into you where you are now thinking, oh, this is a matter of concern. So how to address it? Need-based program is available. Funding? Yes, something new research, something you have to do out, there's a funding problem. So we have to convince the funders for your projects, for your research, and obtain that. So your own colleges, your own funders, you may have to look out that because there is limited evidence as on date. So unless until we address that, it's not going to be solved. So unless until you have research evidence available in all corners of your medical education, it would be a challenge. So to conclude, do you agree? Gender does matter in health. For gender mainstreaming in health.
For a few questions for Dr. Jagdish.
Yeah, if you have any questions.
Let me just begin by asking you, after that wonderful presentation by Dr. Jagdish, why do you think it is necessary that we integrate gender in medical education? Would it have certain benefits? Anyone? And anyone who answers, we'll have an interesting prize for them. Would that make you answer? Why is it that we need to look at disease, disability, health issues from a gender lens? Okay.
That is each one equality. We have to ensure equality.
Okay.
As a woman, I am also a part of the society. I should also have the access to all the services.
Okay. Access is one issue. Okay. Yes. Yeah, I think we'll circulate the mic that we had. It was audible enough, I think. So we need to provide services to women, or we need to have a gender perspective, because the woman is the center of the household, and if she falls ill, the entire household would stop. Is that a gender perspective at all? No, if it's not, or if it is, why is it not, or why is it? Anybody? Okay. Do you think? Yes. Yes, please. Please.
The woman is
I'll come to you.
In a male-predominant society, every facility is male-centered. Like most of the facilities are male-centered.
Okay. Male-centered facilities. Okay. That's one thing we can just highlight. Yeah. Anything else? There is someone.
That's why we must incorporate
Any disease other than biomedical causes. What are the causes that impact it? Social causes. Stigmas, culture, mental causes, right? Social, economic, cultural, psychological causes. And that's what gender is. You know, I'll reiterate a little bit to again try and bring all of us onto the same platform. Gender, what is gender? He talked of what is sex, what is gender. Sex is biological, gender is socio-cultural, right? Gender is a social construct by which society defines certain norms, behaviors, expectations, roles, responsibilities for men and women. And the kinds of roles, responsibilities, behaviors, norms that are defined by society vary for men and women. Men are supposed to do more productive work. They're supposed to work outside the house, and because they work outside the house, they have access to resources. That's a very important thing. You just remember that. Women generally are to work within the household. They're supposed to undertake what is biological reproductive tasks, more unproductive tasks, tasks where there is no resource attached, and also productive tasks outside the house. Now, because of this broad difference in roles, responsibilities of men and women, what happens is, because more men are involved in productive causes, they have more access to resources. And women have lesser access to resources. And because men have more access to resources, what happens? Who has power? किसके हाथ में सत्ता होती है? जिसके हाथ में साधन संसाधन हो, right? So men automatically go up in the societal ladder, and women start becoming subordinate because of this entire issue of power relations. Okay? And because of this power relations, women are subordinated. Because women are subordinated, what happens? They do not have access to resources, maybe assets, decision-making ability within households, etc. And because they do not have access to all this, there is differential treatment towards them in everything, be it healthcare, nutrition, education, everything, including all kinds of discrimination. And because of this discrimination, even their access to health broadly is different. If you see, most women are taken to healthcare centers for pregnancy or childbirth related causes. For other general ailments or illnesses, they are taken at much advanced stages of illnesses. Whereas, that's not the case with men. Right? So, that is where we are talking of, how gender can impact health of men and women differently. Now, let me, even before talking of the Maharashtra example, give you, just take out the pages that you have. Just take a plain sheet and just divide it into two parts, and you're all, aspiring doctors, very soon you will be doctors, and presume you're posted in a primary health setting. Okay? I'm not talking of a tertiary care hospital for the time being. And you have clients coming to you every day. Okay? You have men, you have women. On one side of the sheet, just write what are the common ailments that women would come to you for, and what are the common ailments that men would come to you for. Just do that exercise very, very quickly. Quickly, just divide, write at least 10 ailments that women would come for, 8 to 10 ailments that men would come for. And common ailments that a woman would come to for just primary health. think we'll just stop here. You must have written 4, 5, 3, right? Now, who's going to read out what are the common ailments for women that you've written and what are the common ailments for men? You, three of you. Okay. Start. Missed periods. Okay. Lower abdominal pain. Discharge. Backache. Dizziness or weakness. Edema. Okay. And the males? Oral ulcers. Remember that, huh? Okay. Hernia. Breathing difficulties. We talked of something here, huh? Okay, breathing. Fine. Also. Okay, hoarseness of voice. Fine. Thank you. Would you like to read? Okay. Infertility and menstrual disorders. Okay, can we have a male student here read out what you have written? Would you volunteer? बोलिए कुछ भी जो भी लिखा है आपने एक चीज बोलिए अलग जो लिखी है वही चीजें लिखी है anybody wants to you would like to volunteer? Yes, wonderful. Renal problem. Okay. Now I'll ask you one question. She read out the list comprehensively. You people added. All the women's problems, are they related to reproductive health? All of them, right? Then only they come. And men's problems are related to lifestyle, right? Okay? And does reproductive health problems or do reproductive health problems further get aggravated because of socio-cultural causes? Just give me a minute. Delay. Multiple workloads. A woman has to be in the house, look after the sick and elderly, look after the children, look after her husband, do all the household chores, and if she has time left, then she will look after herself, and then if she has time left, she will go to the hospital. Right? So isn't that a socio-cultural aspect that we need to take into account when we provide services? Right? Right? That's what, or that's why we need a gender perspective. I'll have two more examples, but before that, yes. Tea, yes. Before we start presentation, we'll have the tea break, but one more example I'll ask you. 27-year-old Sumati has come to you. Don't open, just open the pen, right? And through the material. Syrups, files, I've put together what says Economic and Political Weekly. Is a collection or compilation of articles that were published in the Economic and Political Weekly, and they are about 12 articles which are a review of medical textbooks done by different people. So that's one thing. So there are 12 articles as part of that folder. There's a review of textbooks of forensic, PSM, community medicine, gynae, etc. So that's what it is. Guidelines and protocols of the Ministry of Health and Family Welfare. Ministry of Health and Family Welfare in March 2014 came up with guidelines and protocols for provision of care to survivors or victims of sexual violence or assault. What is it that you need to do to provide care, collect medical legal evidence, maintain chain of evidence? So that's there in that. Then we have a WHO guidelines for health professionals for dealing with women survivors of sexual violence. That again is a very, very simple guide on how is it that you need to deal with women survivors of sexual violence. Then there are two booklets. One is an information booklet for medical officers, and the other is a facilitator's guide on violence against women, a healthcare issue. And this is brought out jointly by UNFPA, the National Commission for Women. So those are there. You have the WHO ethics guidelines for conducting research. We also have given to you the WHO multi-country study on how to respond to women facing violence. And we have the May 24 in gender medical education. There are several explicit and implicit gender examples of gender discrimination in textbooks. And we will look at a few of them, and the invite I sent to you had looked at culling out all those experiences. In fact, the EPW that I talked about just now has these articles which bring out examples of gender discrimination, the language that is used in textbooks, how it is, how a lot of practices can really offend the dignity of women. So there are several of these which continue to be present in medical textbooks even today. 2, violence has not been understood as a health issue. And this is in spite of the fact that the health sector is probably the first contact point for women who have faced violence, because it's a non-stigmatizing contact point. Any woman who has faced violence will not have any stigma to go into a health sector. And she's been beaten up, she's been battered, she's hurt. She would like to go there, talk about her issue. But till recently, violence was understood more as an issue to be dealt with by law enforcement agencies and not as a health issue. So that's another reason. Also, we've seen that there is a steep decline in sex ratios. You know, the number of girls being born per 1,000 boys, which is defined as the sex ratio at birth. There's been a steep decline. Today we find that there are only 906 girls being born for every 1,000 boys in our country, which is a huge deficit. And this happens in the confines of the doctor-client relationship. The doctor, by revealing the sex of the unborn child, wants to make, you know, a quick buck. And because of our patriarchal society, we talked of power relations. You know, men get more power or in society, women are subordinated, and because of that there is a strong preference for sons. There are several other social, cultural and economic reasons why families prefer sons in a patriarchal society, and this cannot happen, you know, unless medical professionals are involved. Also, we see that sex disaggregated disease data is not present. We talked of, and Dr. Jagdish had several examples of how medicine or medical textbooks are heavily biomedical, and we discussed certain aspects, you know, in that little exercise we did, that there is no discussion of social and cultural aspects impacting women's health. And there is prevalence of sexual harassment and violence within the health sector. If you see the 2 sectors that employ maximum number of women in our country are the health and the education sector. And again, within the health sector, if you see, there's a huge amount of power relation. If you look at doctors, several doctors are men, and you know, those were examples given by Dr. Jagdish as well. And if you look at nursing staff, several of the nursing staff are women. And because of this, there is one power even there, and even otherwise between men and women, there is a lot of sexual harassment and violence within the health system, which is not addressed, and that's again another reason why we need to really engender medical education. Now in the next about half an hour or 20 minutes maybe, I will look at each of these issues and we will see what we have done in Maharashtra. Very quickly take you through some of the examples of gender discrimination from medical textbooks. Quoting from a textbook of surgery, you know, it said, while talking of breast cancer, spinsters, childless women and those who have not suckled their children are the usual sufferers. Like I said, talking of breast cancer, it occurs in women who have been denied the usual functions of the breast. You know, medically, if you look at this statement, a woman who has not breastfed may be at a slightly higher risk of getting breast cancer. But look at the language. Again, like I said in the introduction, what are we doing? We are merely reducing a woman to a quote-unquote reproductive commodity, if I may use the word. A textbook on forensic, and this is Dr. Jagdish will pardon me for, you know, he's from the forensic department, asks doctors to be careful of women who have been raped. The author warns doctors that women could be falsely claiming of being raped. And this is alleging rape, yes. And in this textbook, several practices which go against the dignity of women, like the two-finger test, etc., continue to be talked of for examination of victims of sexual violence and sexual assault. I'm not going to touch upon that. Padma is going to touch upon that. Quoting from another textbook on psychiatry, it says, physicians are to mitigate maternal anxiety by telling a woman that a woman with a child enjoys better status in Indian society than a woman without a child. Again, going back, how is it that we associate a woman's role only as that of reproduction? Obstetrics and gynecology, sterilization is recommended for women with treatable mental illnesses. Trying to draw direct correlation. She's mentally unwell, and so you give her sterilization. Masturbation in a young virgin after puberty produces leukorrhea. Or, cases of morning sickness have a neurotic basis. So I leave it to you to just decide how gender sensitive or insensitive our medical textbooks or the language used in these are. Now we said violence is a critical health issue, and I'll just take you through some evidence on that and see why is violence a health issue. Like I said, health institutions are an important entry point for women facing violence, and healthcare providers are likely to be the first professional contact for women and girls who have experienced violence. That's probably the first place where a woman who has been beaten up would go to without any stigma being attached to going into a hospital. And they are strategically placed to identify and help women victims and survivors of violence, but they have several complaints saying, oh, we're too overburdened, there is no privacy, we cannot discuss it, etc., etc. We need to see how is it that we can put this entire thing into place. If we were to look at some data on violence, just see how high it is. About 1/3 of women in the 15 to 49 years age group, and this is data from the National Family Health Survey, which was done, said that they have experienced physical violence. 9% of women in that age group said that they had experienced sexual violence. A total of 35% women in 15 to 49 years of age said that they had experienced physical or sexual violence, and around 40% women said that they were victims of violence within their house or victims of domestic violence. What is the health impact of violence against women? And here, we can directly draw a correlation of violence being a critical health issue. Women who reported domestic violence were more likely to report poor or very poor general health. 15.7% of pregnancy-related deaths in the community and 12.9% in a hospital were associated with domestic violence. A one-year study of suicide cases in Delhi found that 56% of suicide cases were women, and when they tried to analyze reasons, marital discord was found to be one of the key reasons in most of the cases. And violence has a very great impact on women's mental and emotional health, completely eroding their self-esteem. If you were to look at the health impact of intimate partner violence, WHO has said that women who are exposed to intimate partner violence are twice as likely to experience depression as compared to those who have not, are 16% more likely to have a low birth weight baby. 42% of women who have experienced physical or sexual violence at the hands of an intimate partner or their spouse have an injury as a result of this. And about 38% of all murders of women globally were reported as being committed by their intimate partners. So that's the impact of intimate partner violence. Well, if you were to look at broad consequences of violence against women, you find that there is an increase of pregnancy-related complications and, care-seeking behavior of women. It increases the risk of unwanted pregnancies and induced abortion. It significantly increases chances of fetal, infant, and early childhood mortality. It is very, very closely linked with sexually transmitted diseases and other gynecological morbidity, and is also positively correlated with poor mental health. if you were to see when is it that women are most vulnerable to violence, we know that most women are always vulnerable to violence, but the chances of women being vulnerable to violence increase at the time of pregnancy, generally with the abdomen being targeted. You know, in case of long-standing illnesses like tuberculosis, HIV, AIDS, a woman who has undergone hysterectomy, you know, because it's presumed or believed that quote-unquote her reproductive values have diminished. So again, you know, drawing a direct correlation between violence and health. And as of now, our medical textbooks, our medical curriculum does not look at violence as a critical health issue. Now we see the entire issue of sex selection. I said it's possible only with the confines or involvement of doctors. You know, it happens in the confines of the doctor-client relationship. Just to talk a little about statistics. If you want to look at child sex ratio, I mean that's the statistics we get out of the census. That's the number of girls in the 0 to 6 years age group per 1,000 boys. That's how child sex ratio is defined in our country. We find that since 61, from when we have 0 to 6 years population figures available, sex ratios have declined continuously from 976 in 61 to 927 in 2001 and 918 in 2011. So today we have only 918 girls per 1,000 boys in the 0 to 6 years age group. If you look at the trends in decline, you will find that 61 to 71, 71 to 81, there has been a decline trend. But the trend is more predominant between 81 and 91. And if you were to see why, you will, you know, see that it was the decade of the 80s when, you know, tests like amniocentesis and sonography were very, very widely available or became widely available in our country. And, you know, the ultrasonography machine, which was supposed to be used for detecting abnormalities and anomalies, was started being used for detecting the sex of the unborn child and eliminating if found to be female. Well, this is something which is pretty shocking. If you were to look at estimates of missing girls per year, and if I were to calculate on the basis of 906 being the sex ratio at birth, right, I just told you a little while ago that there are only 906 girls being born for every 1,000 boys in our country today. Well, let me ask you a question here. How many girls do you think should be born for every 1,000 boys? What should be the ratio?
Minimum 950.
950. You said equal.
Equal.
Anybody else?
I said sex to maintain the lower sex ratio.
He's right. Generally, if you were to see, between 952 and 962 girls are born for every 1,000 boys. Now, to put it in a layperson's language, the reason is that the female sex is the biologically stronger sex. And if you were to look at mortality under age 5, if nurture was the same, I'm talking of nurture, upbringing, there was no discrimination that we talked of a little while ago, then under 5 mortality is much higher in boys as compared to girls, and it is presumed that by the age of 5 years, there would be equal number of boys and girls. So 952 is generally the number of girls that should be born for 1,000 boys. So ideal sex ratio at birth should be 952. But today in India, we have a sex ratio of birth which is 906, clearly showing that there is some kind of human intervention. If I were to calculate on the basis of 906, the sex ratio at birth, we find that every year in our country, 5.7 lakh girls go missing because of the practice of sex selection. And if you were to look at it in terms of percentages, 4.6% of total female births are sex selective eliminations. And you know, sex ratios at birth being different every year, if I were to calculate, over the last 8 years, 4.5 million girls have gone missing from the country's population because of the practice of sex selection. Just to tell you a little about conditional sex ratios. You know, that's the possibility of a family having a girl or girls. While there is no significant difference in sex ratio at birth for the first child, If the firstborn is a girl, the sex ratio at birth for the second child drops to 836. And if the first two are girls, it further drops to 768 girls being born for 1,000 boys. Third parity. This is not my data, this is an article published in the Lancet in May 2011. And this also brought out another interesting thing, that if the firstborn was a boy, then sex ratios at birth for the second child were close to normal. And that this phenomenon is more predominant in the educated, socio-economically well-off, rich people. Well, that was the case a little while ago, but in 2001, when the government of India actually recognized this as a very, very critical problem that the country is facing, from then until 2011, we see that this trend has spread from the urban areas to the rural areas and even tribal areas. If you were to look at 2001 census, you found that most of the districts having good sex ratios were tribal districts, but now if you see, there is a declining trend. Even in this, sorry? Yes, this is for India. This is for India. I'm not referring to any particular state now. Now, what are the consequences or implications of declining sex ratio? Well, it increases violence against women and sex-related crimes. We know that there's been a rapid increase in rape. You might say it's because of increased reporting. Yes, it is because of increased reporting, but also, because there are lesser number of girls, and that's one of the consequences. Polyandry. Several states like Punjab, Haryana, Rajasthan, Gujarat, where sex ratios were low traditionally, from, if you were to look at census, the last 3-4 census will tell you that in these states, sex ratios were very, very low. For example, in 2001, Punjab had a child sex ratio of only 798 girls per 1,000 boys. Child sex ratio. The previous decade was close by. So girls there, almost 20-22 years, are missing. So what is happening is that there are lesser number of girls of marriageable age, and so what families are today doing is that they marry one girl to more than one boy from within a family. So polyandry is on the rise. Abduction and bride trafficking from, if I may say, quote unquote, the girl surplus or the women's surplus states, like you have Orissa, Jharkhand, which are tribal, which traditionally had better sex ratios. Girls are being trafficked for marriage and uprooted from their socio-economic milieu and taken to another state just for marriage. That's one thing. It's impacting health of women, physical, mental, reproductive health. I mean, just imagine a woman who's been giving birth to children, girl children. She may be physically beaten up, blaming her for giving birth to girl children, mentally tortured, I'll leave you, desert you, bigamy, and reproductive violence, sexual violence, repeated pregnancies, repeated eliminations, or even if there are no eliminations, repeated pregnancies in the desire to have a particular sex composition of the family wherein there would be 1 or 2 male children at least, and it has resulted in increased sexual exploitation of women. Reason that we don't notice the consequences or implications of this is because implications are visible across generations. When we talked of availability of women of marriageable age, this is something that would have happened a couple of decades ago and across geographical locations. When I talk of abduction and trafficking of women for marriage, it's, say, a woman being trafficked from Jharkhand or Orissa to a northern state. So it's across geographical boundaries or geographical locations. But if you see, ultimately sex selection impacts or results in increased violence against women, and we have discussed that violence is a critical health issue. Also, we have discussed that something like sex selection cannot happen without the involvement of a medical practitioner. So, we've discussed extensively how medicine is heavily biomedical with little or no emphasis on socio-cultural aspects. Just a little example, if you were to talk of maternal mortality, the common reasons, if I would have asked you, would have been hemorrhage, sepsis, unsafe abortion, obstructed labor, eclampsia, etc. But our medical textbooks or doctors will generally not talk of the socio-cultural causes, which is early marriage. We had your teacher here who talked of early marriage, child marriage, early pregnancy, early childbearing, repeated pregnancies, very low birth spacing, and this entire issue of accessibility and availability of services. Also a huge provider bias. I mean, this is something which we generally ignore. I mean, I really wanted to ask you that question, but because Steve was waiting when you said sterilization, you know, if you go down, and this was a little, I will not call it a study, but we just went around Maharashtra and we asked doctors the same question, you know, in the field, that if there was a woman who had 5 children and was pregnant for the 6th time and she came to you, and all those who said sterilization, all of them, in fact 99.99% of them said they will offer tubectomy. You know, so how there is a provider bias even for offering services or contraceptive services particularly to men, because it's considered that the burden of contraception should be borne by women. So, you know, that's another angle we need to take into account when we talk of engendering medical education. This is engendering provision of services as well. That's why I said services, environment, you know, basic things. Violence within the health system, I've already discussed it, but like I said, it's one of the largest employers of women. Violence faced by nurses, midwives, frontline workers and women doctors is generally neglected. And there's another very interesting thing, and a study in Rajasthan, I could not get access to that study, but there's been a study done in Rajasthan which said that women living and working at peripheral facilities who do not have access to safe housing and mobility are far more vulnerable to violence and harassment at their workplaces, and mostly from doctors within the system. So this is another reason why we need to engender medical education. Now, talking of what we did in Maharashtra, the broad aim of our program was to incorporate a gender perspective in medical education. Well, before we started, and this would be very interesting to you, Sehat, this is a program that was supported by UNFPA, is being undertaken by the Center for Inquiry into Health and Allied Themes. It's being supported by the Maharashtra University of Health Sciences and also the Department of Medical Education and Research. It was thought by Sehat that they would undertake a situation analysis of participating colleges to find out you know, what gender awareness meant to faculty and the non-teaching staff there. What were the biases and apprehensions amongst medical teachers and support staff regarding engendering medical education, and also to get their opinions, suggestions and challenges on integrating gender in medical education. So Sehat actually did the study with 60 medical teachers. They did in-depth interviews, 24 support staff and 12 students from the 7 participating medical colleges in Maharashtra. What we thought, as a pilot, we will involve 6 government medical colleges and 1 private medical college for the program, and then these 7 medical colleges, in order to increase the pool of trained faculty available on gender, will do regional workshops with other medical colleges in the state. So from the pilot medical colleges, the study was done, and the preliminary findings of the situation analysis, and you know, when I think pretty much expected, were that most respondents understood gender only in terms of women's health concerns. उनको health problem है, इसलिए probably there is need for gender. Gender was understood as a matter of improving communication between a doctor and a patient, especially if there was a male doctor and a female client or female patient. And another thing that came out was that gender perspective in medical education was there because of the increasing instances of violence against women, and because now there are more women who are coming into the medical field and who are there in the medical, as part of the medical workforce. So really it was not about gender, but these were the broad perceptions that they came up with. What were the broad interventions that are being done? we thought that from the 7 medical colleges, it would be important to build capacities of medical college faculty on gender through a trainers program. From every college, 5 faculty were chosen. Faculty where there is a direct connect on gender. So the faculties were chosen from preventive and social medicine or community medicine, psychiatry, forensic, obstetrics and gynecology, and internal medicine. So we thought that over a 10-day period, we need to build their capacities on the issue of gender and how gender is linked or closely linked with medicine. And these faculty will in turn go back to their medical colleges and start integrating a gender perspective in medical teaching. Now simultaneously, what is being done, and it's just going to be, in fact it's begun today, is the second phase of this training of trainers program, is that after the training of trainers program, faculty from each discipline is going to be attached to a mentor. The mentor and the trained faculty would together identify areas where, modules on the issue of gender. One is a broad module on gender, 2 specifically on gender-based violence, gender-biased sex selection, where they could be integrated as part of the medical curriculum. And once that is done, not when it's completed, but simultaneously we undertook advocacy for inclusion of these modules within the curriculum, and the advocacy has been ongoing with the Maharashtra University of Health Sciences and the Maharashtra Medical Council, because ultimately it's the Medical Council who would permit change in the curriculum. What is it that we would need to do for advocacy? Undertake a baseline and an endline, to assess the impact. So there would be a baseline study of the students who would be trained by the trained faculty and an endline assessment. We've constituted a technical advisory group and a working group. The technical advisory group and the working group has representatives from the Maharashtra University of Health Sciences, the Maharashtra Medical Council, the Department of Medical Education and Research, the Public Health Department, experts in the field of gender, and the medical associations, professional medical bodies. One is to guide the project, and 2 is that once the modules are presented, they would vet the modules to see where and how they could be included in the medical curriculum. Once they are vetted, then we propose to present them to the University of Health Sciences for broader discussion in the Board of Studies and the Academic Council, and issue guidelines for incorporating this into medical teaching, and then take them to the Medical Council for inclusion in the medical curriculum. So we are midway through the project. I think I will just stop here saying that we are midway into the project, and we hope that by the end of the year, one is we would have developed modules, 2, the advocacy is an ongoing process. We have been advocating with the University of Health Sciences, the Board of Studies. We've been advocating with the Maharashtra Medical Council so that the curriculum inclusion can happen. Simultaneously, Sehat has also been very, very closely talking to writers of textbooks to see how, gender discrimination in textbooks or the language used can be changed there. And, certain of the issues that Dr. Jagdish brought out, no conducive environment. We faced several of those issues. One was that, in fact, even deputation of faculty was a great difficulty. But what we did was, from day one, we involved the Department of Medical Education and Research, and they actually sent out a letter to the deans. We had an environment building workshop with the deans and requested the deans to depute the faculty. In spite of that, there's a problem in Maharashtra. A lot of the candidates who come in are bonded candidates. So when they came in, over a period of 6 months, when they were to go back and incorporate gender issues in the teaching, in fact 50% of them left. So we again went back to the DMER to tell them that, what is it that we need to do? So they again redeputed people. So there was a repeat training for these people. The issue that he raised, non-availability of reading learning material. Because of that, Sehat has come up with a virtual resource center. It's a live resource center, www.gme.sehat, which has examples of integrating gender in medical education from across the globe. What is it that can happen. It's a live center, so people who've undergone trainings like this also share their experiences. So all those issues that he raised, we actually faced those issues, but you know, we're taking one little step every time to try and see how we could address those. So that's about the Maharashtra experience, and we hope that once the Maharashtra University of Health Sciences takes it up, then it would be easier to put it onto a platter and, you know, take it to the other universities of health sciences. Thank you. If you have any questions, we can answer those. Alternatively, we could take up questions, you know, at the end of the 4 presentations, because a lot of the questions would be overlapping. I leave it to you. Any questions, comments? Yes, sir.
Sorry, am I audible?
Yes, you are.
It was a very nice presentation. If you do enjoy it, I just want to highlight important things what we found in our recent programs.
Yeah.
It was really nice presentation. We enjoyed it. What I want to highlight is that about the child adverse sex ratio. What you showed was 918 because that we could probably obtain
That
from
is child sex ratio
child
from
sex ratio.
census.
Yeah.
At birth, it is 906, which is available from sample registration system.
Yeah, exactly. So what we did that we analyzed data of Maharashtra state of last 32 years, and we saw the trend, how it's going. And unfortunately, we are doing really bad. It is about 895 or 890, around 890. So it makes sense overall that this is really necessary to be focused. There are more number of people or task force required to work on sex ratio. So that's the one point. And secondly, we did an analysis of some hospital data, and what we found that those women who have existing at least one male child, they are better taken care of in the subsequent pregnancies. As a result, birth weight of those subsequent babies were found to be higher compared to the previous pregnancies. So these were the 2 points I wanted to highlight.
Very, very important
Yeah.
points that you highlighted. Yes, sex ratios are declining, but in the last 3 to 4 years, there is a slight upward trend in Maharashtra.
It's only urban region. Rural areas, they are doing pretty bad. We did the joint point analysis. Hopefully this paper will be coming in JAMA in next few weeks.
There is a slight reversal in trend in Maharashtra. I'm not talking of other states, and that's because of the fear of implementation of the law there. As of today, the government has convicted 64 doctors in Maharashtra alone. Well, one is about the act implementation. 2 is very, very important, is to change mindsets and really address the underlying causes for unwantedness of girls, which goes back into this entire issue of patriarchy. But yes, there is a point to be taken there, and I appreciate your raising these 2 points.
I just want you to comment from 2011 data, about 654 doctors throughout India that were convicted because of improper record keepings. So, what do you think about that, basically? I know this is a bit ongoing. Yeah.
This is the questions on sex ratio. I will answer them during lunchtime.
Sure.
Because,
Thank you.
pardon us,
Yeah.
this is a session on integrating gender in medical education. It's very important to keep records. I'll answer that question, and I'll also tell you what the court has ruled, but I don't think we will take it up here.
Thank
Is
you.
that okay? And if any of you are interested, right after the 4 presentations, we'll meet out and I'll answer that question. Any other question, comment, suggestion on the program? No. If that's not the case, then maybe I will request Padma to make a presentation on how violence is a critical health issue and what does it mean to provide women-centered care. So she'll talk of that.
Just to draw your attention that you all have a brochure on the project, so you can go into the details of it. And on the 3rd page, there is a site which is provided, gmesehat.org. I would encourage all of you to register and use that website, because much of the evidence, papers, modules have been uploaded on this website. So it's open. You have to just send us an email. Go click on that website, send us your email, you register, and then you have full access to this website. You can actually write about your experiences. There's a blog that we have put up there, so I encourage you to do that. Now coming to this whole issue of violence against women, being a public health issue. I think Anuja has kind of brought in the prevalence and saying that it is a critical public health issue. What we're going to do in the next 30 minutes is really looking at what does it really mean for the health system and health professionals when we say that violence against women is a public health issue. And before we do that, I think we need to really understand what is violence against women and why are we talking about it as a health issue. What is violence? What is violence? I mean, I've put it up. It could be any act which could be of the nature of physical. Physical is very easy to understand. Emotional, psychological, sexual or economic. Yeah. Violence is always an intentional act. So it doesn't happen by mistake. So what happens by mistake is an accident. But what happens, what we call violence is intentional. So the act is intentional. And what is the intention? The intention is to hurt, it's to humiliate, it is to put down someone. Violence always occurs from someone who is more powerful to someone who is less powerful. And when I say power, it's not just the physical strength. The power that is accorded by society based on what we've been doing since morning, gender. It could be because of caste, it could be because of class, education, place of residence, whether you're, if you're living in a metro or you're living in a village or a town, that kind of, our entire society based on various of these parameters decides who has more power in society and who doesn't. And that is what is the inequality which exists in our society, and violence therefore is a tool to maintain that inequality, because violence is an intentional act to control people and keep the status quo as it is. Yeah, so those who are in a position of privilege would maintain their privilege by using violence as a tool to keep those who are less privileged where they are. Is this making sense? Do you think it is making sense? Do you don't agree? Or you agree, you don't agree? What is it? It's making sense? So today we are going to specifically talk about violence against women, but we must remember that this violence against women and the discussion around it is not in isolation with other violence that happens in our society. There's caste violence, communal violence, there's violence by the state. Until that violence exists in the larger society, this violence against women that happens within homes and within communities is all the time sanctioned. It's something which is acceptable as a norm. Now, let's look at what are the common perceptions about violence against women. I'm sure many of you have heard them or maybe believe them. So let's look at it, and I want some responses. The man is sad or mad, then bad. So he's not a bad man. He may be just sad that day, or he was emotionally disturbed, or he must be having some disorder. How can any man beat up his wife so brutally? Must be some personality disorder. How, whenever brutal rape or brutal physical assault occurs, they'll say, these men must be, psychologically there must be something wrong with them. Is that so? If you look at the prevalence, 1 in 3 women globally facing violence, then from an intimate partner or a male, then so many men are have a personality disorder. Or they are so sad, such sad men in our society. Yeah? Do you think, are these perceptions that you've heard, or am I just making them up? Have you heard them?
Yes.
Can't hear?
Yes.
Yeah? Do you think you agree with these perceptions? No. But they still persist, and they are not just out there, but they could be amongst us in some different forms. It was all booze. That's another common perception. It's all alcohol. Have you heard this? These men drink and they beat up their wives. Very common. Remember, the fact is that all alcoholic men are not abusers and many abusers are not alcoholics. We run a crisis center in a hospital from 2001 and we have data for the last 14 years. And what we find out of these 4,500 women whom we have ever spoken to, 75% women have said that their husband has no addiction of any kind. So only 25% women reported an addiction either of alcohol or gambling or drugs. So that is evidence. She deserves it. उसने कुछ गलत किया होगा. She must have done something wrong. He's such a nice man, right? If he's beaten her up, she must have done something wrong. Now tell me, if somebody does something wrong, is violence justified? She may have an extramarital affair. That justifies his violence? Does it? No, I'm asking you a very, kind of stretched question, but seriously. So she does have an extramarital affair. So is the husband justified in beating her up? If the husband has an extramarital affair, is she going to beat him up? She should not, but he should not either. There are differences which can be resolved by other methods. So this, she deserves it, is a very common feeling that if she has done something wrong, she didn't take care of the house properly, or she didn't cook, she didn't take care of his parents. And this is supported through, it's not just men, women also believe that. Women believe that if I fail in my duty as a housewife, as a mother, it's fine for my husband to beat me. So those are the norms that one is talking about. She provokes it. This has been last 1.5 years, ample debate around rape and sexual violence. And all the time it's about, she asked for it, she provoked it, what was she wearing, why did she go at that time, why was she roaming around at night with her boyfriend. So it's all about what she did rather than why was he there. So she went with her boyfriend doesn't mean she was inviting other men to kind of, have sex with her. So this is a common perception that exists. It cannot be that bad, or she would have left the man. And this we hear a lot from medical professionals. What are you talking? She's been here, even if you help her, she's going to go back there. Or if a woman says, I've been beaten up, I want to register a police complaint. We've observed in emergency rooms, and doctors have said, if he's beating you up for the last 15 years, abhi kyun bol rahi hai? It can't be so bad, right? If it was so bad, she would have walked out of the marriage. For women, one has to understand domestic violence, just the term itself, domestic violence, family violence, intimate partner violence. Look at the contradiction. What do you think of domestic or family or intimate partner? What does it denote? Yeah, what does it denote? What would intimate partner for you mean? Emotional attachment? It would mean support. What else? Economic support, emotional, love. Yeah, it would also be love, caring, trust. But what is it? Violence. So for women who are experiencing domestic violence, it's not so easy for them to come out. Because it's from someone whom she loves. It's not stranger violence happening on the streets. Where somebody comes and gives me a slap, it's easy for me to say he slapped me and drag him or whatever. But this is my intimate partner. I'm dependent on him for several needs. Physical, sexual, emotional. So it's not easy for me to come out and speak. So when we say that, it must not be, if she's lived with him for so many years, it couldn't be so bad as she's actually narrating. So you kind of start your whole thing with a disbelief. Now what are the violence and health linkages? So violence of any kind, you all are medicos, you will agree that it has a physical and or psychological trauma. Yes or no? Yeah. Now what are those kinds of consequences? They could be fatal outcomes, they could be non-fatal outcomes. Fatal outcomes are homicides, suicides, maternal mortality. Non-fatal could be physical, which are direct injuries. They could be chronic health problems, which are, where women are coming to you with repeatedly the same problems, and the underlying cause could be domestic violence. There are reproductive health problems, like unwanted pregnancies, PIDs, etc. Because many women who face domestic violence mostly are less likely to have any control over their sexuality. They cannot determine when or whether or not to have sex with the husband, because it's usually they are more likely to face forced sex in their marriages, and unwanted pregnancies, no use of contraception are some things that are bound very likely to happen in cases of domestic violence. There could of course be a lot of mental health outcomes. Now going back to this, it's not just that violence has health consequences, but certain health conditions such as mental health problems, or it could be tuberculosis, any illnesses which have a stigma attached to it, may trigger off violence in women's lives. So when we are looking at violence and health, we have to look at it in a much more comprehensive way, that violence may have direct, indirect consequences on health, and certain health conditions may actually trigger off violence in women's lives. Why should the health sector respond? It's because of the high prevalence. It could be the underlying cause of injury and ill health. If health workers know about a history of violence, they can provide better care and services for women. So you're not just treating a person symptomatically, but you will be able to provide better, full, comprehensive care. There's a legal mandate for health professionals to respond to violence against women. Both the domestic violence law, which came in 2005, clearly carves out a role for health professionals in responding to domestic violence. Also, to provide care and justice. Both are obligations of the health professionals. Medicos also have a human rights obligation to provide the highest standard of care. You all have heard about right to health care? Have you? No? Yes, the General Comment 14, which talks about what is the right to health care for people. So it's availability, accessibility, affordability, and quality. 3AQ. Yeah, so there's a whole human rights instrument, and the General Comment 14 under the economic, the Economic, Social, Cultural Rights Covenant establishes what is that right to health for women. And for survivors of violence, if we don't look at it as a health issue, then we are not even, we are not fulfilling that right of survivors. These two, they can actually prevent further episodes of violence in women's lives. Accessibility in to a hospital is much higher because it's a neutral place. A woman can follow up for services saying, I'm going to the hospital. She's not going to a police station or an NGO or any other helpline. I just want to draw your attention to the law that has changed in 2013, where the definition of rape has changed. Have you all read about it? Yeah? So now rape is not just peno-vaginal penetration. It includes all forms of sexual violence. It includes all orifices, vaginal, anal, oral. So, I think that makes a huge, and look at the consequences that it will have when such rape victims come to you for medical legal examination. You can't now just focus on the semen swab vaginal collection. You have to really understand what has happened. All hospitals it is mandatory for all hospitals to provide treatment, public and private. So this is the legal mandate that comes in for health systems and health professionals. Now what are the numbers that we are talking about? Anuja spoke about the NFHS, and she brought in the fact that this is based on NFHS, which is 2005-2006. What we've done is we have used that data and looked at the population statistics latest available, and this is the number of women who are probably facing violence, which is a large household survey. And if you look at other data from other small community-based studies, you will find that the prevalence rates there are anything from 50 to 60%. So that's the kind of gap that we are talking about. How many actually may be facing violence, how many actually report it during a survey. And now I would like to draw your attention to those who sought some help and those who sought help from the police. And if you look at how many support from the police in the last 12 months, it's about 2,90,000. Are you with me? Yeah? So just remember this figure. And now look at the NCRB data, which is from the police records, which is what is reported, which is registered in the police records. Now for the same year 2013, what you find is if you combine all crimes against women, the total number of cases registered is about 1,37,000. Whereas when you extrapolate from the NFHS data, you have about 2,90,000 women who may have approached the police. So there is a huge gap in the kind of evidence and the numbers that we have. So I think the take-home message from here is just to say that we don't have reliable evidence. We don't really know, we just know that it's high. It's probably much higher than what comes to us, and that's the only thing that I want to establish through showing this, that those who actually face, how many report, how many reach the police, and how many may even follow up with those cases and reach final legal outcomes. What is the role of the health system? Now just to understand the context of what health system are we talking about in India, yeah? It's compromised access to quality and affordable healthcare in our country. We all agree? Agree or not agree? Does every citizen in our country have a right to healthcare? Are they getting? Yes, yes, we have a right. We have a right. But is that, yeah? It's fulfilled? Yes or no? No. No? Okay. So there is a compromised access to quality and affordable healthcare. There is a huge shortage of health personnel, human resources. Now this is a very contradictory issue. The shortage of health personnel is in the public health services. If you look at the number of doctors being produced by India, it's large numbers. And we did a kind of, we don't have any registry which gives you an idea of how many passed out, where are they working. That kind of data just doesn't exist in our country. So at Sehat, what was done was we looked at how many graduate and we looked at how many are working in the public health system. And we found that if you look at that gap, it almost shows that about 90% of those who pass out are working in the private sector. So that is the core reason for this whole shortage of health personnel. Existing gender differentials in access to healthcare, we've I think discussed a lot since morning. Health expenditure is largely out of pocket in our country. Have you heard the term out of pocket? Yeah? Health economics, health financing. Yeah, so basically the government, when we say out of pocket, it is literally people having to pay for their healthcare. And in a country where healthcare has to be bought or purchased, what does it mean? Who gets the healthcare? The rich, those who can afford. So if you can't afford, you are not going to get it. Increasing presence of private sector, which is completely unregulated. So there are no norms, no regulations for the private health sector on how they should, if they are setting up a hospital, what is the kind of human resource they must have, what is the kind of qualified staff that they, so this is the larger context in which we are talking about this issue. Now coming to health system and violence against women, it's not understood as a public health issue, it is not mentioned in health policy or program. There is no training on the gender-based, nature of violence against women, absent in medical and nursing education. There's in fact violence by the health system, as you see in the form of forced sterilization, coercion for family planning methods, and they are all directed at women, violence in labor wards, violence against women health workers themselves. So this is the larger context in which we are talking about this. Now coming to the providers' attitudes and the current response to violence against women. This is based on interviews with doctors, okay, in several sites. So it's Bombay, it's Delhi, it's Madhya Pradesh. It is not recognized as a health issue. Most doctors say it is a personal matter, it's a law and order problem, police should do something. Why, doctors as doctors, we really don't have anything to do with violence against women. There's a huge reluctance to get involved. It is considered to be normal and an integral part of married life. Some kind of violence is there, wo to hota hai. And these are I'm talking about senior doctors, and these are the kinds of perceptions they have about domestic violence. There's a lot of victim blaming. You know, these women, these young women are like this, women, you know, ask for it, they trouble men when they come home tired, so, you know, they are nagging, therefore they ask for this violence. There's also this perception that it happens in the slums, amongst the poor, and amongst the religious minority community. ये हमारे में नहीं होता, वो कहीं और होता है. So domestic violence doesn't occur in the educated, in the Hindu community. It happens in the Muslim community, illiterate, poor, in the slums. So these are very strong notions, and actual data is very contrary to that, which I hope you all agree, or if you have a difference, please put up your hand. Sexual assault examination is ridden with stereotypes, and these are all quotes from, you know, these are the common perceptions. Most complaints of rape are false, since they must have consented. It is difficult to rape single-handedly a grown-up and experienced woman without possible resistance from her. What does this mean? It's not just a simple statement. What it means is that if she has no injury on her body, that means she consented. Instructs doctors to note the previous character of the word. Medical textbooks 2013 editions have words like deflorated women, pink vaginas. I mean, you know, it just doesn't make any sense, at least to me. I'm a non-medical, but I don't know if it makes sense to you either. Determining whether or not a woman is sexually habituated. And the textbooks go on to actually say, I mean, I really wonder where these authors and where they are really, you know, which ancient times they are living in. And they don't think they need to give any scientific evidence on it, but they say that by mere examination of the breasts, the shape and size and, you know, of the breast, of labia majora, of labia minora, you can actually determine whether a woman is sexually habituated or not. And they say it with so much confidence, and nobody is questioning them. And I'm sure many of you have read them, because these are those 4 very popular forensic textbooks. And many of you, which is second year, right? So all of you have already crossed the second year. There's a whole preoccupation with signs of resistance. The other problems in the current response to specifically sexual violence is there's no standard protocol. There's often delay in providing health care, because the preoccupation is with medical legal evidence collection. Lots of insensitive practices like the 2-finger test, you know, so commenting on the size of a vaginal opening. So 2-finger test is not equal to the per vagina examination. Per vagina examination is a clinical tool. But to comment whether a 1 finger went or 1.5 finger went is basically commenting on the size of the vaginal opening, which is to really, why is that comment being made by doctors? To really comment on whether she is sexually habituated or not, which has nothing to do with the current episode of rape that she is reporting. She may be sexually habituated, so what? So what? Is that the role of the doctor to find out how many times she's had sex in the past? That's not, the law also doesn't ask for that. Irrelevant comments on the status of the hymen. Instead of just noting if there is a injury or not on the hymen, they'll get into whether the hymen is present, not present, whether it's an old tear. Now, how is an old tear of any value to the current examination of the rape that she is reporting? There's an overemphasis on presence of injuries. There's poor history taking. Most doctors, we found, I hope things are changing, and I hope when you become doctors, things change. There's a huge reluctance to talk about rape. There is a lot of discomfort. So there's no language. See, the victim also has no language, because in our society we don't talk about sexuality, right? We don't talk about it. But for doctors, it's important. If you're there as a, you know, somebody's come to you, if you don't ask properly, how are you going to treat? But there's no language. So therefore, doctors need to be trained to have the language which will help them to really ask about sexual violence. Gait and mental state are other stereotypes that exist amongst medicos. There's this perception, and again it's rooted in textbooks, where the textbook says that a woman who's raped will find it difficult to walk. So a rape victim is asked to walk in front of the doctor. Most ridiculous. All of you here who are women, I mean, unless you have a very, very severe genital injury, you're not going to wobble. You're not going to walk with a lot of difficulty. And in most rape cases, there are no injuries. There are no injuries. And this is not just evidence from India. Globally, only 1/3 cases of sexual violence would report any kind of injury on her body. Mental state. There's this perception if she's raped, she must be like, she should be absolutely disabled, crying. But there's evidence that women cope with these incidents in different ways. And 50% women may actually show emotional distress, others may not. And remember that a woman who's reporting rape to a hospital has gathered up the courage to reach there. And I think instead of validating and appreciating that, one is actually checking whether, oh, okay, she was smiling, talking, so pata nahi, true hai, false hai. That's none of the job of the doctor. Let the courts decide whether it was rape or not. What needs to be understood is the limitations of medical evidence. Medical evidence is often taken as the most scientific and litmus test kind of thing. Medical test, uska negative aaya, rape nahi hua. That is how it is understood. But the limitations of medical evidence, and you all are medicos, you will understand that when was the examination done? The gap between the incident and the examination becomes important. If it happened 2 days back and she's come now, it's important for you to record because your clinical findings are going to change. Documenting that therefore becomes important. When we are talking about genital injuries, these are mucosal injuries. They heal fast. They may not therefore be visible if there's a delay in reporting. What has she done after the assault? Did she urinate? Did she clean herself? And most women whom you actually speak to, if you ask them this, the first thing for them to do after rape is to just clean themselves because they feel so dirty. So if you don't ask this and you don't record it, what will cleaning and urinating do? All your evidence is lost. Use of condom, which is often used in rape, but that information is not there in our medical forms. So was the condom used? Was there ejaculation? Did it happen on her body? Did it happen outside? Because you are looking for the semen swab, right? You will find semen if there was ejaculation. If there wasn't, you are not going to find it. So no medical evidence does not mean that no offense took place. And I think that's the take-home message for you. What is then the essential response that is expected? The health sector is expected to make inquiries about violence based on the presenting symptoms. So if there are injuries, women will often say, I fell down. But you can make a distinction, look for inconsistencies between the history and the physical examination. Accidental poisoning. So many women will report with accidental consumption of poison. Is this something that you have seen for those who are 4th and 5th year when you actually go to your wards? Accidental consumption of poison. And when you get into the history, it's half a bottle of insecticide. Can you accidentally consume half a bottle of insecticide? You can't. So it is an attempt to suicide. But it's not even recorded by us as a suicidal attempt. So if we don't record it, we fail to even care for her. So there's no suicide prevention counseling that is done. So I think, the specific role therefore is to really make inquiry, document details of the history of violence such as time, date, by whom, instead of just saying alleged history of assault. Go beyond that. Provide immediate treatment, provide psychosocial interventions and aid the entire criminal justice system if she chooses to actually fight her case. These are some examples of clinical conditions associated with intimate partner violence which are there in your pen drive. This is the 2013 clinical guidelines for responding to intimate partner violence and sexual assault. Do look at this, and these are the ones that are associated, and the recommendation is that if a woman or a patient is reporting any of these symptoms, please ask about domestic violence. It's quite likely that women reporting with such health complaints are likely to be victims of domestic violence. what is minimum required at the health facility to ask about violence? We are getting into practical issues now. A protocol needs to be in place. Training, because they are not trained in medical education. So unless the doctors are trained on how to ask, they are not going to ask about violence. There needs to be privacy in which you can ask. Confidentiality has to be ensured. You have to not only promise it, but also ensure that her papers and her files will be kept in confidential place. Otherwise, she will not be able to speak out about what is happening to her. System for referral needs to be in place. You, as an individual doctor, once you ask, what are you going to do if she says she is facing domestic violence? Do you have a helpline that you can refer her to? Do you have a social worker you can refer her to? So that system of referral becomes absolutely essential. What does intervention mean? Does it mean giving information? So what is the role of the doctor? Is it to give them information that yes, you are facing domestic violence, go here? Is it just mere referral? That okay, it's a case of domestic violence, go to this social worker? What does intervention mean? If you as a medico, if you are intervening and you are going, if you are saying that health system must recognize, is it just giving information? Of course it is important to give information, of course it is important to provide referral, but it's also important that the intervention questions abuse and the power inequality. It should not reinforce the same gender roles. So the intervention should not tell her that if he's beating you when you don't cook well, why don't you learn cooking? That intervention is not going to help her because you're reinforcing the gender roles. So the intervention needs to question abuse. She may actually cook the food that her husband likes. That's besides the point. But the abuse and the violence needs to be first questioned, and she needs to be told that that's unacceptable. The intervention must make a distinction between violence and conflict and quarrels. Often when we work with doctors, they say, "Ye to ghar ka jhagda hai." What is jhagda and what is violence? Are these two same? Yeah? Seem to be same? No? Are they different? Why? ये घर का मामला है, घर में झगड़ा होता है मियाँ बीवी का, उसमें उसने मार दिया उसको. What is the difference? What's the difference between any act that you will call violence and what is it that you will call a quarrel or a jhagda or a conflict? Okay. Okay. Anyone else?
Quarrels are not the intention factor is lacking in
Quarrels. So quarrels and conflicts, one would say, are between equals, where both are expressing their difference of opinion. They are arguing with each other. There could be arguments. But when there is violence, it is a act. It's intentional. It's over. It is to exert power. Principles for intervention. You all must have looked at ethics. You all in second year, is it? When are you taught medical ethics? Second year? Yeah. So you must be familiar with these terms. So it's autonomy, and I think when you're intervening in violence against women, these principles become very important. So you must respect the autonomy of the woman. So you may feel that she needs to, she's faced so much severe violence, so she should now she should be sent to a shelter. She may choose to go back. So working on violence doesn't mean getting all women who come to your clinic and who report violence to the shelter. No. Women need information, you need to question abuse and link them up to services so that they can make their own choice. So respect her autonomy. Beneficence, whatever you're doing, it should be for her good. So you can do it only if you're well trained and if you have the available services and referral networks in place. Non-maleficence, do no harm. If you think, if you can't help, just don't touch her. Leave it. She's better off without your intervention. Justice, don't discriminate based on caste, class, community. Now applying these principles means, what does is autonomy? How do you translate autonomy as a principle into your medical practice? Informed consent, everyone has heard about it. How is informed consent taken? It's verbal. So what does it mean? It basically means that the person needs to understand all the information in her language. So it's not just for your protection. What we have seen in practice is informed consent is taken from the perspective of protecting yourself as doctors. Tomorrow I should not get into trouble. No, informed consent is about respecting her autonomy. So giving her complete information and seeking her consent before you move ahead. Respect for the dignity of the client. So be sensitive, patient, attentive. Counseling and seeking and reaching out is a big step for a woman. Even to tell a doctor that her husband is beating her up is not easy for her. Privacy, confidentiality, we've also already discussed. And confidentiality and its limits. So if there is mandatory reporting clause, you must inform her that this is what is expected by me in this hospital. So I will have to do a medico-legal case, or I will have to call the police because you are reporting with a grievous injury. So whatever may be your law. So confidentiality is not just in the air. Understand it and contextualize it to your existing protocols and hospital rules that you are working in. And competence. Remember that you need, competency becomes a very it's an ethical issue, I feel. So knowing and having complete knowledge of what intervention you are beginning to do becomes very important. Now WHO 2013 again has brought in a concept called women-centered care. Now what does this women-centered care means? It means that being non-judgmental and supportive and validating what the woman is saying. What does it mean? What do you think? Is it easy? What does being non-judgmental mean? Listening to whatever she's saying and documenting whatever she's saying, validating what she's saying, without questioning it. Yeah, you are not there to prove that violence occurred. You just listen in such a way that you validate whatever she's saying and place the onus on the larger oppressive system, not on her. Yeah, providing practical care and support that responds to her concern but does not intrude. So give her information available on services, on where she can go. The fact that she doesn't, what is underlying behind this message? That she doesn't have to live with it for the rest of her life. There are options. And convey that to her in a way that she believes that there are options for her. Asking about her history of violence, listening carefully but not pressurizing her to talk. So if she is not willing to tell you details of it, it's fine. Just write down whatever she has said. So they don't get into, women who are facing domestic violence may not, and this is evidence-based, may not be able to narrate what happened to them in the way you would like patients to tell you the history. So she may tell you what happened yesterday, she may tell you what happened on the day of her marriage, and there may be 10 years in between. So please be sensitive to that. So listen carefully and go with her pace. From the doctor's perspective, you need to look at few issues, which are what is the severity of violence, helping her access information about resources and legal services, assist her in increasing her safety, help her if there is any chance of her going back and getting killed because the violence has escalated to such a high level, then you need to do some different intervention. So assess that safety and talk to her about it. Providing mobilizing social support. So these are the this is what is defined by the WHO as women-centered healthcare. So this is like practically saying what is possible for you to do. Is this possible? Yes, it is possible. Such models have been demonstrated in our country, elsewhere, and they are working well. There are health professionals who have, who are asking about violence and responding very sensitively. I'll leave with this, that the public health approach to violence at the primary, secondary and tertiary level, you all are medicals, so I'm sure you understand what a public health approach to various diseases is. So violence against women is not a disease. It is a social issue, it's a human rights issue. But a public health approach would basically mean this. And I leave this slide open here. With that, I end my presentation. And if there are any questions, any thoughts, any reflections, any examples, please feel free. None? Yeah.
I want to say that as you have said, there may be no evidence of bias. Maybe there is no evidence of bias. That means, how can we be sure that whether she is actually has abuse history or not? There are some cases they may try to have a false histories. So that cases, how can we be confident that she has actually had a history of abuses?
Okay. Now, the history of abuse, it's a very important question. History of abuse is given by her, and you as a doctor are expected to document it and examine her. You don't find any evidence, you are going to mention that you did not find any evidence on her body, but this is the history that she gave you. Let the court decide whether she is telling the truth or not. As medical professionals, it's really not your responsibility or not your job to decide whether she is telling the truth or not. Yeah? And give her information. If it's a false case, it will fall apart when it goes to the criminal justice system. What I am trying to establish here is that most women who face rape may actually have no evidence on her body, and there may not be any injury on her body. So absence of injury does not mean that she is telling lies. She still needs health care, and she still needs services. And why does she have no injury on her body? Because of the nature of sexual violence. The way sexual violence takes place is, nobody just goes out and, brutally rapes. I mean, those cases are there. They are just 5%. Stranger rape and brutal rape are 5%. Most sexual violence takes place by known people. So it's a planned act. You know when there is no one, you take her away, you may create a vulnerable situation where she cannot run away from. Often women report that they were so numb, they were so shocked that somebody who's her uncle or her neighbor who's suddenly on her. So they were just shocked, they were numb. That doesn't mean that she consented. So I think that's what I'm trying to express. Any other thoughts? Yeah. No, I can't. Maybe you should speak louder. Hold it closer to you. Hi, yeah.
I attended the workshop and it was very nice. And your organization has also been carrying out a lot of studies. Now, I think the only thing is sexual violence or these discrimination happens for men as well as not just women. This confidence mostly first for women and
Yeah.
more happens for women. So I think this patriarchal system of power relation may also go down with these doctors and society gets to know that it happens to men equally as with women. So there are ways to deal with that as well.
Okay, I'll answer that. Any other question? Yeah.
Nowadays we are often coming out with the
You need to be loud, hold the mic.
nowadays, like girl child abuse cases are more coming up. In Bollywood movies, also they show quite often. So how am I, as a medical professional, to deal with a girl child who is already shocked with that incident, as well as how do I, take out the facts and evidence from her?
Thanks. There was one more question and then I'll respond to the 3 questions. Yeah.
Many times it happens that the woman who is presenting to the doctor, she talks about her health problems, but she does not stress upon that she is abused, she is being abused,
Sure.
or she is a victim of violence. And how we as doctors can detect that she is actually being abused,
Sure.
so to give her a better life.
Okay. to these two questions, which are very specific to what you can do, I think there was not some aspects I have covered on how to ask, but there are clear protocols on how to ask about sexual violence to a child, and I can direct you to some of the resources. There's the Ministry of Health guidelines which have been issued in 2014. It has an entire section of how to talk to children, and it also has an entire section of health symptoms as presented by children. So it's burning micturition or any kind of vaginal discharge. You have to ask about sexual violence, because when a child is reporting with certain symptoms, it's not a very normal thing to happen. So I would really request you to look at that guideline. It also has very clear pointers on how doctors should ask for history of sexual abuse, not only for children but also adulthood, because it's not very easy to get it out also from adulthood. Your question about how do you know, and I think it's about therefore training, that you need to, she may not report and most women may not, and therefore the whole issue of identifying violence. One is reporting violence, where a woman is coming and telling you that she's facing violence, then what is it that you do? Second is, you can see that this is probably violence, but she's not telling you. So how do you ask? There are different ways of asking, and there are different tools for that. You can ask her directly, or you can say that many patients that I have seen who have reported with this health complaint actually are facing violence at home. Are you one of them? So do it sensitively as part of clinical history. So your message to her is, you're not here as a police officer asking her whether atyachar hua ki nahi. You're saying I'm concerned about your health, and is there something happening at home? You have someone who's repeatedly coming to you with unexplained probably health issues. Ask her that I've seen you in the last 1 month so many times. Is something happening at home? You can talk to me about it. I think that's the way to break the ice and get her to talk. Now coming to your question about men, and very rightly, gender system and patriarchy affects men and women, but it doesn't affect them equally. It oppresses women, but it privileges men. Men do face violence. When I say privileges men, it also tells men what to do and what not to do. So men who want to be sensitive are told by patriarchal norms that you can't cry, you can't be sensitive. Even if your father's died, you can't cry because you're a man. Right? You can't really care for your child, you are the breadwinner, and you have to, young boys are told how they should walk, how they should talk, because you're a man. And this whole sexual performance, men have the highest anxiety about sexual performance because that's how the pressure in a patriarchal society is. So definitely it does, to that extent, put a lot of pressure on men in our society. But I wouldn't say that that is equal, because it actually, disempowers women in many ways. It is discriminatory against women. Now, men and violence. Yes, men do face violence. If you look at the statistics of men facing violence, a lot of this violence is from neighbors, from street fights happening outside the homes. What is happening within homes is really violence against women. We don't have such reliable data from India, but in the US, of all the intimate partner violence, 5% is violence directed at men by their female partners, but 95% of intimate partner violence is directed by men to women. So I think, one needs to, and of course one doesn't, though they also need support services. A lot of violence takes place against men in prisons, in interrogation, torture, sexual violence, and in conflict regions. If you look at the reports in Kashmir, Jammu and Kashmir, you find large number of adult men facing very brutal sexual violence. And as medicos, one needs to recognize that this happens, so that when men come to you, you must also ask about sexual violence to men, especially in conflict regions. Large number of men, and I would draw your attention to the MSF report, Medico Sans Frontiers. Their report, you can just Google, you will find it. And they have stories of sexual violence reported by men in Kashmir, by state agencies, by the police, during torture, and by militants. Does that to some extent answer your question. Okay. So thank you.
Thanks, Padma, for that nice presentation.
Thank you.
We've been told to break for lunch. Do you want to stay on, listen to another presentation on it's on gender, ethics, and clinical and medical practices, or would you like to break and come back?
Life and professional life comes, and if you look back at your life and think of the people who inspired you as teachers, you would find they were the people who walked the line they taught. And those are the kind of people, and it takes a lot of effort to walk that line. And what I'm going to do is to create that enabling environment for all of you to at least recognize whether you want to walk a certain line. And you can see the very, very interesting changes that have happened in the practice of the medical profession. Where now the Medical Council of India for a few years ago, at least 10 years ago, 2002 I think, notified the ethics code, and it has been systematically correcting the code of practice for professionals by saying you cannot take money from pharma company for following activities, how your relationship should be, what is the nature of transactions you should have. So it's actually, for once you see a profession and you have to admire them for it, that a profession is actually dictating to its guild members the code of ethics. We often assume, no, this code of ethics is something which our houses, families have taught us. We are born human, we are social, we are brought up in our houses to be a certain way. So naturally, ethics would come to us. We are not born to do bad things in life, so we would automatically do ethics. We would be ethical beings. But sometimes, this understanding of morality of what is right and wrong and the way it gets transferred in professional practice are two different things, and that second part of how to behave and how to do things is partly a learned behavior. It's not necessarily instinctive. No? So if you learn it, if you have to learn, we learn many things from our society also. No, like today whole morning you have listened to a discourse on learning to, you are born as with male genitalia. What I'm going to do is to tell you how to recognize various vulnerabilities, gendered vulnerabilities, to define the ethics and help you to identify the implications for ethical medical practice. And in this I'm taking three cases on which three situations where there is either legislation in this country to some extent or pending legislation. So this is something which Jagdish, starting in the morning, to everyone has reiterated. I'm not going to go into that. Basically, to set the stage by telling you that gender refers to the biological differences and sex refers to the biological differences, and that gender is the economic, social, cultural attributes and opportunities associated with being male or female in a particular social setting. What was interesting was the question that people asked in the morning, that is everything that there is to know about the biological differences actually known? See, if Jagdish was telling you today morning about the way MI presents itself in women and how that is not recognized. Was there never any MI in women in an earlier time? That it only happened later? That only now MI in women is happening? Possible. People themselves never lived long enough. But biologically, on an average, women live 5 years longer than men. So they should have had MIs in the earlier times as well. We never ask those kind of questions. We don't ask the kind of questions which are relevant to women because they are not important enough if they get relegated. So even biologically what happens to women, that is how sex differentiated experiences are, leave alone gender, are not fully answered. So sometimes we don't even know. Why don't they get asked? They don't get asked because the valuation of women is different from the valuation of men. So our imagined MI is more dominant among men. Case fatality rates is more among men. It's thought to be more among men. So classic presentations form the discourse surrounding MI, and therefore even very well-trained physicians, cardiologists would miss its presentation in women, and therefore women would die. At that time, are you not failing your women patients? And is that ethical? Here actually not to do anything is malfeasance, they would die. So that is why you need to recognize both the sex-based differentials. That also needs to be learned. If your textbooks are the way they are describing, that means you only understand the way it presents itself in men. Your pictures, your figures are based on male ideologies or male ideation. So if you have to now in that abdomen there has to be a uterus, you need another picture, right? So when someone said, why do you need to address these issues? It was for equality. Now this is very simple and easily said. Gender, we throw words, equality, equity, discrimination. I thought let me set the stage by quickly telling you exactly what this means. When we say equality, it means equal treatment of women and men in laws, policies, equal access to resources and services within families, communities and societies at large. It does not mean the same MI rate for men and women. The same incidence and prevalence rates it does not mean. It means it's a socially structured thing that equal treatment of women and men in laws and policies, equal access to resources within families, communities and societies at large. This is where you say there is no equality. Because for many laws are unequal, sometimes when the laws are equal, the practice of that or the way the law is taken recourse to in the society is different. Way families perceive needs are different. Way teaching systems teach people. I have a lot of medical students who tell me that boys when they go for the gynec practice, when they have to learn for they are deputed to learn in the gynec departments, they are sidelined. Because either women in my state do not want to be treated by men, or most of the teaching doctors are women, so the boys are sidelined. And the same thing happens to orthopedics or forensic medicine in certain parts of the country. So there is a practice which results in, so when women need to be dealt with sensitively after certain issues, and they may choose to have, not necessary to believe that all women will be sensitive to women's sensitive needs. But if we need a woman in certain professions, we won't find them. So you have a society which is unequal, you have unequal number of practicing orthopedics, more men than women. And that is again an unequal world. So to make up for it, what do you need? You need fairness and justice in the distribution of benefits and responsibilities between men and women. So often it may require women-specific programs to exist to take away or reduce or end existing inequalities. So when you say equity, sometimes you may have to be doing a bit more for men, sometimes you may be having to do a bit more for women in order to achieve an equal world. It's like this a bit. To ensure a fair selection, you all get the same test, you must all climb the tree. If you have different capabilities, what people will achieve is different. The aim is to build a world where everybody has a chance to become what they want to become. And gender discrimination is a distinction, exclusion or restriction made on the basis of a socially constructed gender role or norm which prevents a person from enjoying full human rights. Now supposing I want to go and see a film at 9 o'clock in the evening. Many of you go to college, many of you have full practices, you have to finish your assignments, do whatever it is you do. You may have no other social roles to fulfill, and the best time to see a film is the 9 o'clock show. How many of you can take a decision to say, today there is a nearby whatever, IMAX or whatever, let me go there on my own and see this film and come back? Can you put your hands up? You live in India? Okay. IMAX next door? Yeah. See, other than that, most of us can't. But can we find out why it is that you can't go? Safety issues. Is it true for all the men here? issue of safety or the issue of transportation? Not transportation? I am not just asking the women. There are some gentlemen who care to answer that. There are no places to see movies at 9 o'clock for the men. They are not allowed to see movies after at midnight. So you are afraid to go at 9 o'clock for safety reasons. So why are you not seeing movies at 9 o'clock? You never see movies? No, the reason is this. The reason why women don't go is very different from the reason why men don't go. And that is a discussion.
Roberts or something goes on is a
restrictions from home, okay, for young boys. Now is it the same for people in third year? For boys as well? No one from third year? Very interesting, remarkably silent gentleman. The key ethical principles is, we've had our colleagues talk about it, Padma has referred to it. You have beneficence, non-beneficence, autonomy and justice. Now, how does this play itself out? And I'm just going to take a few examples. When we say beneficence, it's actually a principle of do good. The second one is do no harm. When you say autonomy, autonomy is recognizing that each person has control over their own choices and recognizing the right or their right. Actually, autonomy, when recognized in the patient, calls for a lot of effort on the part of the treating doctor or surgeon or whoever to make the effort to enable that person to exercise autonomy. Why is that? Why does this doctor or treating person have to make so much effort to enable that autonomy to be exercised? Why? Why do you think? Come. Why does the doctor have to do something to enable an exercise of autonomy? Why do you think? Yeah, that is exercised through informed consent. The way you implement your respect for autonomy is by consent. But why is that information informed so important? Why is it important to know?
My idea is different from the patient's idea. He may feel something else is better for him.
Okay.
That's why he takes all the
Actually, in terms of knowledge, who knows more about the disease? The doctor. So there is an asymmetry in knowledge. You know more about the condition that is there and that person doesn't know. So if I have to make a decision, I am not a doctor, no, and actually the only biology I know is in 10th standard. I haven't studied any biology after. So it's important for you to know that. Okay, so when I falter, I look to you for assistance. You definitely know more than me on those matters. Why is it important? It's important because patients don't know enough about the knowledge that you have. Now, if you have to make me make a decision about what has to be done to me, that knowledge which you have has to become my knowledge also. Only then can I decide. You are not supposed to decide for me. I have to decide for me. If I have to decide for myself, that knowledge has to become mine, right? So you have to tell me. So you have the knowledge, you have to give it to me. That enabling me to decide, is this enabling me to be an autonomous being, is now in your hands. That calls for you to, that is another reason why when Padma said building your skills is important, it is important because having your own technical skills, knowledge, understanding is important because only then can you give it to me. If you have wrong knowledge, how can you give it to me? You get it? So for me to be an autonomous being here in matters of sickness is so much dependent on you. And then comes this issue of fairness. Justice is the exercise of fairness in your practice. It's very difficult to actually to be fair to others is not very easy. It is also a learned behavior. The easiest thing is to be unfair. To be fair calls for you to make an extra effort. There are 5 people. Random selection by lottery method is very easy. Nobody will fight. First come, first serve. Pneumonia, headache, meningitis, during pregnancy, this bleeding, hemorrhage. First come, first serve. Will first come, first serve work here? Justice helps you to make that decision, exercise of the principle of justice. Fair, who will survive? Whom do I need to intervene in first? Whose can wait? Which disease is more serious? It calls for an exercise of these principles. And effectively, that is why it becomes important in medical practice for you to recognize these 4 principles, not just for research but also for medical practice. Now let's take this case, which is now legislated. There are ethical guidelines for this. Ethics in assisted reproductive technologies and surrogacy, especially. Now what if you read the law, and this is the way I have read it, it's very, very interesting to see one of the most important things that the state seeks to address in that. What it says is, if a child is born for surrogate parents, the child is responsibility of surrogate parents. If the surrogate parents are from another country, the child does not have citizenship rights in India, even if the child is born in India. Otherwise, for all of us in this country, if you are born in India, you are a citizen by birth. All of us are Indian citizens. Most of us here in this audience are Indian citizens by birth. But in ART law, the first right that the child born in India loses is the citizenship right if the parents are not Indian. If the commissioning parents are not Indian. Now, look at this. You see that there is a lot of benefit. Now, who does not want to help people to have children? It's a very noble thing. No? All of us most of you come into medical profession with aspirations to be doing good at the very best and do no bad at the very least, isn't it? So, we start with that premise, and there are a couple who don't have children or are unable to have children. To help them to have children is a very good thing. And so, if they can themselves produce but they can't bear the child, you find another person. There are ways and means. I'm not going into the ways and means of producing this. The child is either biologically partly the parents or both ways the biological child. And it will be legally owned by somebody. Yeah? So is that a good thing? Are they benefiting? Is anybody being harmed in that process? Surrogate mother is accepting, everyone is happy, it's a win-win situation for all. Okay, so nobody is thinking of the mother when she is handing over the child. What if the woman says, "Mere ko paise, I got the money, I am okay." She may be emotionally attached. So is the only loss the emotional attachment? How many of you know a little bit about when is the risk for maternal mortality the highest? Age? No, very young and higher ages, right? Risk is, it's a U-shaped curve. Maternal mortality by age is a U-shaped curve. Okay? How is it by parity? Gravida. How does gravida affect maternal mortality? Increases after the third birth order. What is the required biological children minimum, right? So if you have to have already 2 biological children, you are already into the higher gravida. And these are women who would have already had 2 children. So there will also be age. So the age and gravida risks are both increasing. Is that part of the discourse? Is it part of the consent process? Your risk of maternal mortality goes up by this. Do you still want to risk it? So, if there is a commissioning mother who is tested and we find that she is not able to, she can actually donate her egg, but she is unable to carry the pregnancy to term, so there is a surrogate mother. Now, who is the treating physician for the surrogate mother? Who is the treating physician for the mother who can't bear the child? No, is it the same or different? If it is the same, then whose contract is more stronger for the doctor? Then who is should that be the responsibility of the treating doctor? Is the surrogate mother not a patient?
She is not even aware of the situation that she is in danger.
No, but can we do that to doctors? Can they become like that? Should we not recognize the necessary conflicts of interest they have in becoming, when there are 2 people in adversarial positions? Will a lawyer be the lawyer for the victim and the lawyer for the perpetrator? Does law allow that? But here you have the same thing. And when you think of the long term, does anyone think of the what is the harm in infertility? Why is it that as a society, why is it that we are so much worried about resolving the problem? To produce a biological child. So, adopted children can't inherit. There is a stigma attached to being childless. Is that a biological thing? Social thing. But what is it that our law also, when you look at the way the law is structured in a sense, it is good to help people who are in distress. But it reiterates all of these socially existing things which can be addressed through several other means. First we stigmatize infertility. To resolve it, we come up with solutions, and then we create an enabling environment for those people to address. It's a good thing. With scientific progress, if somebody is childless and it can be addressed, it's a good thing. But it also causes for certain problems to occur, and that is what you need to start to recognize when you get into the practice of medicine. For one example is how legal frameworks can also be at times unequal. You need to recognize, because if there is a consensus on some things, it will become law. If we think that's a good thing, we will make a law on that. But not all of ethical practice necessarily becomes law. Yeah? No. So the next one I wanted to look at it is, yeah, but what? Okay, so then it will get resolved.
The Act has banned the use of technology for prenatal sex determination.
Yeah. But as long as the means exist, I am telling you, who are you? Sorry, I'm just making it up. I am asking you guys, who are you to tell me what I should do? Tomorrow when I have a daughter and I have to get her married, it costs me 10 lakhs of rupees plus so many sovereigns of gold. Are you going to come and give me, you government telling me not to have? I don't want to have a girl. Are you going to help me to get her married, look after her? Who are you to come and tell me to have a girl or a boy? It's my choice. All of you people who come around telling me that I should have a girl, I should not have a boy, or I should let it be, all of these things, you are also the same people who tell me I should choose to marry whom I want to marry. When I want to marry, you say I should have a choice. When I want to choose the person I want to marry, you say I have a choice. What I should do, I have a choice. Now I am telling you I want to have a boy, I don't want to have a girl. So here alone I can't exercise my choice. Who are you to tell me? Now when women ask that, what will you tell them? Think about it. Because see, when we did this, now what has happened in the medical profession as a consequence of this PCPNDT Act? What is the consequence now? We find suddenly a lot of discourse among gynecologists in the community who don't want to perform MTPs. Is MTP targeting MTP? They don't want to do MTPs, they don't want to give emergency contraceptive pills. There is a whole discourse of morality now surrounding this. When you find a majority of the women who are coming to seek even medical termination of pregnancies are not coming because of sex selection or anything. They are coming because they are married and they have become pregnant when they didn't want to be pregnant and they could not exercise choice in using contraception at that time. That is why they are coming and asking for. But instead what you find is a discourse where sex selection is now adversarially positioning itself against MTP, which came into existence to again enable women to exercise choice. That is to choice to not to be pregnant when they didn't want to. And actually, if you look at the history of that particular act, it came into place to prevent maternal mortality. Now, it is in that context you have to think, where can women really choose? Do women really make a choice? Is there a societal environment where they are able to make those choices? Who comes? Or the family. See, she was telling you about the violence issues, and the kind of situations which women come into the hospitals and they come to ask assistance. And very often you will find women will tell you things like, it's okay for my husband to beat me, and something as simple and, how do you say, non-sensitive as the National Family Health Survey, in the sense that if 1/3 of the women tell you they have been victims of abuse, and 1/3 of the women who have been victims of domestic violence say that it is okay to be beaten, and what is the reason why they feel it is justified? The second most important reason is non-preparation of hot food. Is it rational, accepted by women for getting beaten? Is it rational? Which means the conditions in which women are living doesn't really let them make the choices they would have made had they the knowledge. So that enabling environment to have that understanding comes from where? It has to come from people who know that various choices can be exercised. So you need to look at sex selection from two angles. One is, if you have to mitigate against it, how do you go about it? One of the reasons why such a law is actually tolerated as a restriction of choices is because the society in which, the kind of society we would create by exercising sex selection is not a society we want to be in. It is a society where everything she described is prevailing. What was that? You said a word, no, where one girl will be married to many men. Polyandry, that is exercised. Maybe some women prefer it, but do all women prefer it? Is that they take the young girls from one state and say that you are going for employment in another state, and then they get married off in third state. So you actually can't even trace girl A from Jharkhand who went via Maharashtra to Rajasthan. The parents there are expecting her in some employment in Maharashtra. She's actually married to some random person in Rajasthan. And this is the kind of ways you see more violence, more restrictive environment surrounding women, more people saying now you can't wear trousers, you can't wear phones, you can't use mobile phones, you can't go there, and so boys will be boys, and we can now throw acid on a girl who says no to me. Now, why is that happening? That is happening because the less and less women, the more and more commodified they are becoming. So, is that the society where we want to be? And that is precisely why, as doctors, you need to think of, do you want to be living in a world, that world where this is what will happen to women? And that is the reason why you need to work against sex selection in the best way possible. Now, I'm going to take a third example, not by restricting women's access to existing facilities, by saying I am not going to offer MPP, etc. That can be a personal choice, but often it goes that way as a means of preventing sex selection. Not every woman, and most women seeking MPP are not seeking it for sex selection. Then you come across, recently we were in a meeting where a lot of older women were there, and my student who had worked on cesarean sections was really aghast at the epidemic of cesarean sections and hysterectomies in the community, because we now have some kind of, what do you call them, insurance schemes which include both private sector and public sector. And an analysis I had actually showed that most of the C-sections, 75% of the total C-sections happened in the private sector, and a significant contribution to that form happened after it, later on in the evening, in the early parts of the, like on Fridays. Most of them happened on Fridays. We have no reason why C-section should occur on Fridays, but they always happened on Fridays, majority of them. And things of this kind. So you know that it's not a random event. See, if C-sections were happening to women, as a statistician I can tell you, they will be uniform, and they were done for genuine causes. They are normally distributed, meaning that the chance of a woman having a C-section on a Monday is the same as a woman having a C-section on Tuesday, same on Thursday, Friday, Sunday, Monday, any day. Not all problems, then the problems that result in having C-section would be concentrated on Fridays. That's too much of a coincidence. If this happens, you know, dal mein zarur kuch kala hai. You know, you understand that word in, I don't know the Bengali equivalent of that. Okay, so you need to ask those kind of questions, and he asked those questions. And he considered it an epidemic, and he asked the women in that audience, put your hands up, how many of you still have your uterus who are beyond the age 45? Close to 50% of the women didn't have. And most of them did not exhibit any concern. There was a difference in ages when they had actually had their uterus removed for varying reasons. Most of them seem to have very sound reasons. They said this and that and everything. But a lot of them did not have a uterus. Now comes the question that how does it come to pass? We are a society where you all said, no? If people have infertility, we need to treat it. So we have high premium on maternity. Right? If you are a society that sets up a high premium on maternity without valuing women, so maternal mortality doesn't cause us so much concern till MDG goals come along. Till before that we didn't give it, we didn't bother. ये तो होता है. Women have to give birth because it happens. But how much of those maternal mortality is avoidable causes of mortality? We didn't ask the question till someone from abroad comes and says your MDG goals are not met. So when we value maternity without valuing women, non-maleficence, is that not? And we facilitate such a process. How ethical are we? We see women as reproducers instead of independent individual citizens, when we don't respect them for themselves, but only because they can produce a child, only when they can produce a vagina, or you have a uterus and produce a child, or the uterus is no longer required for the state's labor. So it can be thrown out, and in the process it also produces money for the hospital system. One. Second is a dysfunctional uterus requires monitoring. Monitoring means if you have heavy bleeding, you need to talk, you need to work more. As a health system, you need to monitor the woman, you need to make sure she is not anemic, you need to follow the dysplasia to see whether it is causing problems, you need to make an intervention to remove the distortions in the cells, to see how the cell is developing. So the easiest one-stop crisis center, you remove the crisis, remove the uterus. But what are the consequences of that kind of an act? Is it doing no harm? It's actually saving a lot of time. Maybe money also. But is it doing good for the woman? Is it achieving beneficence? Suppose you take away the benefit of having a uterus which results in a cyclical production of hormones, which keeps osteoporosis at bay, keeps musculoskeletal disorders at bay. All of that is lost to this woman, and at very young ages. So what are the burdens to those women? As our health system doesn't cater to those needs, and you as a gynecologist or whatever are not doing the orthopedician's work, and this will be somebody else's responsibility, it doesn't matter. Who is going to bear the cost of that? When I say cost, I don't mean 200 rupees, 300 rupees. I mean the burden of musculoskeletal disorders and concomitant health care burdens and disabilities that the woman is going to suffer in the long run. Who is responsible? And is that ethical?
She's coming immediately for many that actually emotionally do come with the report and proper how the case comes, right? Like she's in a clinical setting and
and our group has come across some of the points which I hope will be useful. First of all, we have come to conclusion that doctors do play a key role in handling issues of violence against women. Be it a physical or a sexual violence, women will first of all approach a doctor and will confide and trust in him or her. Next, we as doctors have to counsel the entire family because they are the ones who will actually help the woman to come out of the problem. And if we don't teach the family, they're not going to stop it if it is coming from the family side. Thirdly, doctors have been designated as expert witnesses. So whatever examination we perform is taken as it is. Now, for improvisation, we have also come across that there are many cases which are left as undiagnosed because the signs and symptoms that come are not actually of violence. So we need to train doctors in such a way that they can ID such patients. Next, the textbooks, the writings and the figures are mostly male-oriented, so those have to be changed. Also, workshops for school levels which cater to all types of audience, be it men or women, and especially the adolescent group, where people have to be made aware and sensitized about the issues such as violence happening again on the women. Lastly, counselors at each level, be it schools, offices, colleges or any organization have to be appointed so that the hesitation to complain about the violence and to talk about such issues can be removed and violence as a whole the problem can be reduced. Thank you. This is what we have.
The changes, commenting changes in the books that we read. I think, is that the topic related to what is given, the debate topic is something else what you spoke. Because it is how doctors are most strategically placed. It is not how doctors need to be modified to tackle the situations. I do think, and the rest is on you.
That is true, but textbooks, if they are changed, the issues of gender discrimination, we are taking the problem to the grassroots level.
are showing male-oriented figures, and the way they write the language, being childless, is like not having a perfect life. So the violence issues come up after all these things are read and all.
Okay, this is a competition, so we will not add or subtract.
Just focus your attention on 3 words: doctors, more strategically, and violence. Now you see, I think they spent an entire day studying on various strategies to combat the violence against women. So as a part of any strategy building within the health sector, I feel there are 3 main primary components: the health sector, which involves health workers, the legal system, and the general public at large. So by saying most strategically, quote unquote, I think we are giving there is no point using the word most strategically, because we are putting an unnecessary burden on the doctors, because if everyone, be it the health system or the legal system, they are equally important in it. Because example, the legal hassles associated with the MTP, I think all of us know it. And second is, in relevance to India, I would like to speak that a violence, or rather women violence, it's more of a social problem. There is a huge social impact on social arena that needs to be addressed. And for that, I think as a part of the, as a doctor or a to-be doctor, I can say it is much more better to address it initially at a political and social level, because it may not be possible for a doctor to go or his work is, there is not much scope, as a doctor. Because in a country like India, for example, I have to show you, I tell you about the mud movement by Farhan Akhtar, Men Against Rape and Discrimination. I think people who are from the political and social arenas need to be working on this, and they will be much more effective, at least in India, where political role and political will plays a major role in guiding any form of strategy development or any form of bills or that need to be enacted for addressing women violence. And last but not the least is we must accept the thing that doctors at the end of the day are humans, and I think we all have a tough time getting a livelihood, be it industrialists or doctors. So whether they confined to the ethical laws that are set by the country is a very personal choice, and it's a very, you cannot hold the entire medical community or the doctor community for that. Whether a doctor follows a set of ethics it's entirely personal and moral ground. Thank you.
Questions?
Please speak also to the mic.
Hello. Good afternoon, everybody. I am Dr. Devjit Sharkar from Arjikar Medical College and Hospital, Kolkata. Our group strongly believes that doctors are the most strategically placed to deal with this issue of violence against women. Firstly, because doctors are sometimes the only person that a woman confides in, because from his days when she is an adolescent, she is going on and meeting the doctor on a sometimes basis till to the point of time she has a child. So, and she gets to speak with the doctor on a one-to-one basis. So sometimes the issues which are on a societal scale cannot be disclosed with others, can be talked with the doctors. Secondly, the doctors, they have the knowledge, and also they are ranged from the domain, from the grassroots to the policy makers. So if they are aware of the situation, what is happening actually, they can champion the cause at the level of policy makers, and then sometime later we have policies or groups which can take up the cause. And also, by the virtue of medical ethics, I feel the doctors are in a position to preach and practice gender equity. Yes, we have seen cases where sometimes the issues of violence, mainly the emotional violence that is taking as regards to gender discrimination, this is one point, but other than that, it's not only the money doctors are after, there are also moral issues, and definitely doctors, by the virtue of ethics, are more poised to take up this issue of gender equity. So that's what I feel doctors are in a good position to champion the cause. And our take-home message is, firstly, do no harm does not necessarily mean do nothing, and secondly, absence of physical injury that we learned today, the absence of physical injury does not mean that the woman is not a victim of sexual violence. And the feedback is, yes, it was a very interactive session, and there are some portions, also like the PNDT Act and the material content of the textbooks, which we were aware of, but not thought of them or gone through them in the light of gender equity, and which enlightened us. Thank you.
Am I audible? Good afternoon to each and every speakers out here and respectable audiences. It has been a pleasure to be at the ISMOPH and to have such good speakers and seminars out here. Now as a part of the debate topic that doctors are more strategically placed for addressing violence against women, I would like to be in favor for that point. Now, to a layman, what is a doctor? Doctor means someone who's placed higher up, considered next to be God. So when a person next to be God, so you have that belief in that person. Now what you cannot say to a stranger or someone else, you can say to a doctor. Moreover, a doctor is known for the person's health problems. Now when violence occurs, you are down physically, you are down psychologically. Now when your health goes down, whom do you consult? The doctor. So the first strategical point where doctor comes is this point, that the person, if by virtue of social stigma, if he or she cannot go to a doctor, then to a police, he can consult a doctor. Now, okay, if I leave the doctor, what else points do the woman have to go? She can go to the police, she can go to a family member, or she can go to a husband or spouse. Now, as stated by the speakers, only 5% of the violence is done by virtue of strangers. Mostly they are domestic violences. Then the point of going to your spouse and family members goes away. Comes to police. You go to the police, face cross-examinations, and you again go down. You go morally down and say that no, I don't want this. Moreover, when you go to the police, you face media problems. The media comes up, what happened, what happened. That also creates a social stigma out there. Okay.
Doctors are considered by the general public as next to God. You are in a medical private public and you are quite aware of the number of times you get beaten up by the public. So do you think gods are beaten up in public? Things like that.
Name anything, I will tell one thing. You read in schools, you had principals. You respected your principals very much. When you go to college, you have VCs. You respect your VC? I hope you should. But every university doesn't do so. They are also considered to be a highest point. They are also considered to be gods because they create gods. No, they are principles, right? They are principles, right?
Okay.
Yeah.
I think next question, last question.
There are 3 questions.
Social stigma is there. By virtue of social stigma, I would prefer that they won't go to the police first, because for a woman, she has to depend for social issues, for financial issues on her husband than on a doctor. If she goes to the police, media problems and
Is there one more group left over? Okay.
For whoever has spoken before, I would again like to stress on the point that doctor is the first person in fact that a woman of abuse is going to approach. Maybe not directly with the complaint that yes, I was sexually assaulted, but yes, she will come with symptoms, and we have the ability, the clinical experience, the knowledge, skills, and we should exercise that in order to recognize the symptoms, come to the right diagnosis, and then give proper counseling. Okay, we are supposed to be in a profession where we have a sympathetic touch. No lawyer is going to have that kind of sympathetic touch. No kind of police people definitely don't. We have seen our FFD textbooks and the questions they give in that. Where were you? What time? All those questions, they question the dignity of a woman, and we have the sensitivity to approach it the right way. So I guess, and also the esteem at which we are put. Maybe not next to God, because even the husbands are considered pati parmeshwar kinds. So yes, we are kept at a high level, and what we say matters. Like they know that we are trying to do our profession in complete honesty, and we should maintain that. And with that approach, yes, we are more strategically placed. We have the right resources, the right people, and so we can counsel her the right way. So, and I would end with that because everyone has already mentioned everything else. Also, our take-home message that concept of equality can be brought about only if we stop objectifying women. We need to
realize she's not a machine to just produce children, and yeah, that's how I think we'll be able to identify that there is no gap exactly in gender. Thank you. It was standing out because we don't usually identify those things that okay, yeah, they have mentioned it only by the male perspective and not given a like
questions.
Like we are yeah, right.
You feel your doctors treat their patient a lot of symptoms. That's what you find.
Yeah, right.
I think you're from the government hospital.
See, you were talking about an OPD where you are seeing hundreds and thousands of patients and
like you go to some government hospital, you see people lying on the ward and they treat it like I was a scientist.
they have been practicing so much time, maybe they have forgotten, okay, what they initially got into. We are fresh doctors, we are taking the Hippocratic oath. I think it's a different stand altogether. That is going to vary perspective to perspective, but what we are being taught to, how much effort we are putting in this field after getting into is to help others. We are getting nothing. Money comes.
One last question. You have no? Try to push them back in the form of a feedback or a debate. There were a few concerns by one of the groups saying that why it should start with only doctors. Somebody should start, I think that was what the response from the other group came. This is an ongoing exercise, as I reiterated in the morning, at all stakeholders, and we should first set our house in order. So that's the reason why the medical fraternity, we are trying to push it and try to see how to keep our house in order. And I am glad that many of you tried to bring out the feedback or the take-home points which you brought out for the entire session. With that, I feel that whatever we put in our efforts to stimulate you and to achieve, I think we have met our objectives of the workshop. So,
Before that, I'd just like to tell you one thing. When we talk of doctors being more strategically situated, and you talk of other agencies like law enforcement agencies, community, etc., generally, a hospital environment or a doctor is a non-stigmatizing environment for a woman who's faced violence to go to. But two, it's only women with very, very long-standing instance of violence that would approach a police station when extreme thing is required. You know, a woman who's facing violence on an everyday basis finds it non-threatening to go into a hospital setup and seek a service. Okay? And there is